Everyone, good morning. Welcome, welcome. So glad that you're here. My name is Doug Wiebe. I'm the director of the Injury Prevention Center and just delighted to welcome you today to our Injury Prevention Research Symposium. Thank you so much for coming. We have a great day of events. Before I begin, I'd like to acknowledge Dr. Pat Carter, co-director of the Injury Center and also co-director of IFIP, Institute for Firearm Injury Prevention at University of Michigan. Also like to acknowledge the amazing team at the Injury Prevention Center, our staff and faculty for putting together this robust morning. I'd like to get started by giving a short introduction to our center for those of you who are new. We're a CDC-funded injury control research center. We're one of 9 academic centers funded around the country, and the center's been funded from the CDC since 2012. Our center has 3 cores: training and outreach, training and education, outreach and translation, and research, all working together to accelerate injury prevention research into practice and policy to reduce the burden of injury across the Great Lakes region and the entire country. As you can see, the Injury Center has a very long history. I joined the Injury Prevention Center only a year and a half ago. I took over leadership from this excellent lineage of leaders, and I'm honored to continue the work that they've started. As I'm sure you all know in this room, it's an exciting time. The field of injury science is in growth mode, not only across the country, but absolutely on this campus at the University of Michigan. Thank you to all those who preceded us and are still here, some not for long. I'll give a special shout out to Vice President for Research, Rebecca Cunningham, who has done so much through her career, and not just since she was in that role, to build injury science on campus. You may know that she's becoming the next president at the University of Minnesota, and we're super thrilled for them and thrilled to still be benefiting from everything that she's helped build on this campus. Now, in this field that is so robust and vibrant right now, there's still a lot of room to make a contribution. Now that I've been in this role of director for about a year, I've been thinking about what this means for the Injury Prevention Center. Of course, injury science here has been around for a long time. There's a lot of great research that we're very proud of. Over time, this research has led to enough funding for new independent centers to be formed. And these include the Concussion Center at the University of Michigan, IFIP, Institute for Firearm Injury Prevention, and also a new overdose institute that we're thrilled is getting launched on campus. With so much injury prevention research going on one campus, there's an opportunity for this center to become a hub. Our center is still unique in that we have 9 areas of focus rather than a single one. Our areas include opioid overdose, concussion still, motor vehicle crash, violence prevention, older adult falls, suicide prevention, adverse childhood experiences, global injury prevention, and other emerging areas. Because of our broad focus, we hope to become a hub and a connector for the other centers and researchers and trainees on campus. And we're in a position, we hope, to really make the whole greater than the sum of its parts. We're looking for opportunities to help and be able to do so. We want to expand with outreach and in-reach on campus and beyond, and take advantage of some of the synergies that's going on. For one, we're working with colleagues in Botswana, and we've submitted a grant to work on the epidemiology of suicide and developing a surveillance system in Botswana that can be a role model for sub-Saharan Africa. Beyond that, our primary colleague, Dr. Maketsi Molefi in Botswana, family medicine doc, epidemiologist, is one in the next class of 7 investigators from Africa who will be coming here thanks to the African Studies Center to spend a whole year on sabbatical working with us. So many opportunities in injury science will be coming from that. Also, leveraging resources and the great momentum on campus. Thank you to IFIP and also the Ideas Initiative in the School of Public Health. They have funded Professor David Humphreys from Oxford to spend also a year with us on campus now, funded to do a very innovative project working on making it possible, more easy to dispose of unwanted firearms. So we're delighted to have Dr. Humphreys with us. We've also now partnered recently with the Department of Emergency Medicine to support master's and doctoral students in epidemiology and biostatistics to work with clinical faculty in emergency medicine on topics of clinical epidemiology, health services research with an injury focus and beyond. So these are the ways that we're helping to make the whole greater than the sum of its parts and put other people in a position to capitalize on the richness of resources that are available here at this robust university. We look forward to continuing to find ways to keep on working with all of you. And it's just great to see so many people who I haven't met before, but are clearly in the injury business. And we look forward to working with you and so glad that you're doing this work. Turning to today, we have a program that takes us through to 12:30 with a sit-down lunch that you're all invited to attend afterward. And what we're going to showcase today is our past and currently funded research projects that are underway now or recently completed, and also the exploratory projects that we have underway at our center. Our goal for this event is to provide a space to foster connections in the field of injury prevention across the university and the wider community. As we've discussed before, there are a lot of centers and researchers working on injury prevention of different types across the university. There are just so many great organizations in our community doing injury prevention work, and we're excited to work with some of them here today. These are folks working on campus and across campus from MDHHS, others in the community, delighted to have you here. We can do greater work, of course, by working together. So we hope that you take advantage of this opportunity to be together. We'll have a number of breaks continually built in to keep on networking and getting to meet each other. Briefly, I mentioned the full lunch. There will be a full lunch served at the end of this event. We hope that you can stay and network with us later. If you'd like to read more about our speaker and view the poster presentation abstracts, you'll find them available on our website and in the information that we've been handing out. Here at the campus, of course, we know the value of incorporating diversity, equity, inclusion, and belonging in our workforce, in our trainees, in the topics we study, in the way that we study them, and the differences that we try to make. And that is the theme of today's keynote address. Our speakers are Dr. Natasha Underwood and Dr. Cass Krafasi. Both are leaders in DEIB, and I'll give you a more formal introduction in a moment. Last night, some of our researchers met with our keynote speakers and invited guests to talk about, to think about how they could be incorporating DEIB better into the research that they're getting ready to launch. This was an important conversation to remember, so we hired an artist to come and capture and annotate the discussion through the meeting. I'd like to share a graphic that was created over the course of that hour-and-a-half meal. This was happening in real time. She was sitting with us, right next to us, and capturing information and putting it up. A couple of nice things pop out of it. On the left side, centering around diversity, equity, inclusion, and belonging. Learning from community. Up at the top, a key point, people tell you what they want. We've got to listen to that. And at the bottom center, we need a bigger table. People talking about inviting everyone to the table, we need a bigger one. So these were themes that came out of last night, and we hope to embody them in the work that we keep doing moving forward. I'd like to give a shout out to Jan Nazaro for creating this work. Okay, without further ado, I will introduce our first keynote speaker, Dr. Natasha Underwood. Dr. Natasha Underwood is the Health Equity Officer at the NCIPC. That's the National Center for Injury Control and Prevention, Injury Prevention and Control at the CDC. In this role, she coordinates research, programmatic and surveillance efforts related to health equity and social determinants of health across the NCIPC. Previously, Dr. Underwood was a health scientist in the Division of Overdose Prevention, where she led a cross-site evaluation of the prevention for states' cooperative agreements and founded and co-led the Social Determinants of Health and Overdose Prevention Workshop. Dr. Underwood completed her MPH at Emory Rollins School of Public Health and completed her doctoral degree in public health at the University of Georgia with a concentration in health promotion and behavior. She's also a proud graduate of Spelman College. Dr. Underwood, we welcome you. Look forward to hearing from you.
Well, good morning, everyone, and thank you for that warm welcome. I'm Natasha Underwood, and I'm currently the Health Equity Officer for the National Center for Injury Prevention and Control at CDC. And this morning, I'm very excited to share the vision and work around health equity that we do in NCIPC, or the Injury Center. My goal this morning is to introduce you all to the NCIPC Diversity, Equity, Belonging, Inclusion, and Accessibility Strategic Plan. I'll go through that in depth and also describe the implementation approach and process that we took in the Injury Center, and then talk about some of our future directions and next steps. With my disclaimer, the findings and conclusions of this presentation are my own and do not necessarily represent the views of CDC or ATSDR. So for the duration of my presentation, I want to walk you through the genesis of the health equity work in the Injury Center, which is where I'm currently positioned. The murder of George Floyd, along with the injustices and inequities pulled back by the COVID-19 pandemic, led to numerous discussions internally across CDC as a whole, but within the National Center for Injury Prevention and Control. We were constantly challenged and questioned by our own staff, but as well as our external collaborators and partners and recipients to change internally, but also address the external work that we put out, and especially address the inequities that we saw and experienced during this very historical and pivotal time. While local and state and even federal partners and leaders were declaring racism as a public health issue, we heard from our recipients, whether that's our state and local health departments, our various partners in the field, as well as our own internal staff members who were working in the Injury Center day in and day out, that we really needed to take a closer look at every aspect and facet of the work we were doing in the Injury Center, from our scientific products to our grants and how we interact with each other in the workplace. This led to the creation of a Diversity, Equity, and Inclusion, or DEI, work group in September of 2020. And the purpose of that work group was to strengthen NCIPC's culture of diversity, equity, belonging, and inclusion. And that small group initially started with 14 volunteers from across our center. And so today, I plan to talk about and share where we've grown since that inaugural group of 14 started meeting in the fall of 2020. And I'll walk you through the vision of health equity for the National Center for Injury Prevention and Control and where we're headed in the future. In the Injury Center, you'll see that our acronym is Diversity, Equity, Belonging, Inclusion, and Accessibility. And that strategic plan was finalized in early 2022. Please note that with our acronym, we include accessibility and being attentive to the varying abilities in our society and organization are important to our center, which is why the A is included. You'll also note that we have a B, and through a series of listening sessions with staff in our center, we felt the need to include belonging as a part of our strategic plan. That B really centers and anchors a lot of our staff in the Injury Center to the work, their colleagues, our community that we are trying to create. The NCIPC, our DEBIA strategic plan, that is our North Star. That is our guiding light in how we achieve health equity, and it guides our internal and external work. And so I'll continue to walk you through the various components of this plan. Our strategic plan identifies transformative goals and objectives to help NCIPC embed DEBIA principles throughout its organizational culture in scientific and programmatic work. As our North Star, NCIP envisions a diverse workforce, an inclusive workplace, and health equity in all we do to prevent injury and violence prevention in every community. Our DEBIA vision and work is a critical element in preventing violence and injury. And for us, we view increasing diversity, equity, and accessibility within our workforce, in our workplace. We can better reflect the populations that we serve across the nation, ensure that our colleagues have the resources that they need to effectively do their jobs, and create spaces where people feel like they can be their true, authentic, and best selves and feel safe in those environments. Throughout this strategic plan, there are 5 guiding principles that cut across all of the goals. And those principles are central to the plan. Those guiding principles are first, highlighting intersectionality and realizing that there are multiple components of people in how they show up and how they conduct their work. That second cross-cutting principle is leading with DEBI, a centered principles and goals. The third principle is highlighting assessments and evaluation and knowing that we can't just keep plugging away at a strategic plan without taking pauses to really assess and evaluate the progress that we're making. And the fourth is integrating equity principles. Our last one is promoting accountability, which is extremely important in a large organization where you are really pushing the needle to advance equity and eliminate health inequities and injury and violence prevention. This is a team effort, and everyone should be accountable for contributing to the goal. The strategic plan is broken down into 3 domains, which you'll see on the screen. We describe our work in these 3 domains or 3 buckets: the workforce, the workplace, and the work. As I mentioned previously, for us in the Injury Center, it is imperative for our workforce to be diverse and contribute those diverse perspectives and lived experience to enrich the work of the Injury Center, while also creating a safe, inclusive, and accessible workplace where those perspectives can be shared, heard, valued, and respected. All of this influences the work, which is the domain I cover, and I'll spend some time really drilling into that. A focus on health equity in NCIPC involves really embedding it and having a focus on the conditions of communities and spaces where we live, we play, we work, and learn into all of the center's scientific and programmatic work. So what does that mean for that third domain around health equity? There are 4 concrete goals, which you see, and I'll talk through various examples on how we are trying to really move the needle and embed this and make it more systematic in our organization. Our first goal is really focused on getting our own house together in the Injury Center by establishing and strengthening internal mechanisms for health equity work. It's important for us to look internally to see what are our gaps and where are we falling short before we tell others and lead the way. This includes actions such as looking at internal policies and practices, increasing our staff's knowledge and engagement with health equity, and also setting action plans to work with our partners. The second goal, our second goal is prioritizing health equity as part of the Injury Center's funding opportunities. This includes having language that emphasizes the importance of community-led strategies that address structural racism and other root causes of health inequities. We're also looking, again, the importance of the accessibility. So we're also looking at how do we incorporate accessibility practices into all of our funding opportunities. At CDC, one of our main and key roles is providing funding to state and local health departments as well as other partners. And so this is a huge investment on how we change what we fund and who we fund and being able to lead with equity in our funding opportunities. Our third goal focuses on building and disseminating the evidence base to advance health equity for injury center topics. Our center covers a huge range of topics, ranging from drug overdose to suicide and adverse childhood experiences. But we also cover topics like motor vehicle safety, drowning, and traumatic brain injury. And despite these topical areas, it's absolutely imperative that we focus on engaging communities that are disproportionately impacted by inequities. We also need to work on expanding our surveillance system to include various social determinants of health measures so that we're getting a better descriptive view of the communities we serve and that we work in. And we're also working on developing and implementing evaluation strategies with a focus on intersectional approaches and really leaning into the fact that communities are different, individuals within communities are different, and we need to really lead and learn from communities. And we're also working on our own communication. Our fourth goal is around the partnerships that we have in the Injury Center. And we want to make sure that all of our partners are advancing equity, that we are all leaning and leading in the same direction, and that we have a reciprocal relationship with partners. We don't want to just take from them and ask them to do certain things on our behalf, but making sure that they feel safe and comfortable telling us and sharing with us the future directions that they need and the resources that they need to really eliminate inequities in the communities that they work in. So I've really covered our big, lofty goals and objectives. And I want to transition to what that actually looks like on the ground in the injury center and how we get these goals achieved. So following the development of the strategic plan, the Injury Center focused on bringing various staff together with different backgrounds and experiences, whether they were project officers, evaluators, epidemiologists, to help us identify and prioritize tasks that would support the implementation of our strategic plan. This led to the development of action agendas to support those three domains that I previously covered. As our center moved from strategic plan to actually implementation and doing the work, we don't just have a pretty document on our website and that we share with staff. We actually wanted to do the work. And so we moved into an implementation mindset. And that led to the development of a DE/BIA council that focused on that workforce and workplace domain and creating action items for that. And you'll see that on the right side of the screen. On the left side, I was able to stand up a center-level health equity work group that focused on embedding approaches and outlining those approaches across all of our programmatic and scientific work. And one of the most intensive efforts that work group took on was the creation and implementation of various action agendas for 2023 to 2024. And those action agendas really break down the lofty transformative goals and objectives into very small bite-sized steps. It identifies the owners and the collaborators and ensures that all of the actions are time-bound so that we can keep a track on how we are making progress with our strategic plan. So, what does actual implementation look like since the strategic plan was formed, since we've invested resources into health equity in the injury center? As I wrap up, I want to highlight just a few milestones and successes that we've had as we've embedded health equity in the injury center. One of the key accomplishments that we achieved was establishing 5 permanent positions, which are leadership positions that advance health equity within our injury center. And for us, that's incredibly important to have those positions in a leadership role because it ensures the importance of the work around health equity and has that visibility, but it also ensures that those individuals have decision-making power to embed equity in the various programmatic areas and the various divisions within our center. We were also successfully able to establish a work group in various action plans and have that be a shared governance document for our center. We are incredibly focused on being transparent and upfront with the staff in the injury center and letting them know this is what we all agreed on. If there are changes and differences, we need to talk about it. But if not, this is how we're moving forward, and this is what we've all consented to. And another key thing that we've worked on is establishing a central hub for communication, training, resources, and just everything related to health equity going on within the injury center, but also agency-wide at CDC. It's a one-stop shop for everyone interested in health equity and how it relates to their job roles at CDC, where they don't have to go fishing around for information. They can go to one place to get that information. As I close today, I want to cover a few things that are instrumental to the progress around health equity in the injury center in various keys that I think have helped us become successful and will be instrumental and foundational as we continue to advance this work. The first is around staff voices and the constant vocalization of needs along with genuine support from leadership. Those are two instrumental things that were successful to the strategy development. Sometimes we think about having a top-down approach or a bottom-up approach. In this instance, we had both swelling together, and that was incredibly important as we developed the strategic plan and had success in moving from just a vision into actual implementation. We also went through a rigorous process of identifying staff from various backgrounds to help draft the strategic plan. Again, it's important to have those perspectives and voices, not only from leadership and not only from staff, but making sure that there's engagement, that there's buy-in and value from all levels of the organization. We wanted to ensure that senior leaders from the top, whether that's our center director, down to our branch chiefs and our team leads, showed up and actively participated and were invested in the vision of health equity for our center. One of the final keys to success that I'll share is the importance of communication. As a scientist, I am super content just to write a report or write a paper and be done with it. But as you are leading an organization and really looking at all of the different assets and groups there are, I cannot understate the importance of communication and doing it in multiple ways, in multiple times. As the health equity officer for the center, as I mentioned, I want it to be as transparent on this journey with all of our staff in the injury center as possible. And that meant frequent engagement with staff, with leaders, and utilizing multiple communication channels. It also means being very forward with the public, with you all. And you all are the people we serve at CDC, the American public and the global community. And so we were able to launch an external webpage to share the goals that I mentioned around health equity. And we'll continue to add content and be transparent on where we are making progress and movement and also where we are falling short. One key that I'd also like to mention is don't be afraid to go bold. The goals in our strategic plan strive to be transformative and move the needle to eliminate health inequities. And as I stated, I use the word eliminate health inequities and not decreasing inequities. And those small nuances in the language make a big difference and is important for the staff and as we lead our work for the public. So don't be afraid to go bold, whether that's in your research or as you're leading various initiatives. As NCIPC looks ahead to advancing health equity in our programmatic and scientific work, we continue to build our own internal capacity for our staff to meaningfully advance these goals and address social determinants of health in our research and our programmatic work. We are also continuing to look at our own internal mechanisms, again, making sure we are working on our own house internally to better embed equity into our policies. And again, that example, as we're thinking about writing these various funding announcements, we really need to lead with equity first and identify the language that we're using. the various requirements and activities that we are asking for those writing and responding to our funding opportunities, and also identifying how these individuals and groups who are responding to our funding announcements plan to lead with equity as well. We're also continuing to look at our surveillance systems and take an inventory of social determinants of health that we currently include in identifying where the gaps are and how we can address them. We're also continuing to look at measures of success. As I talked with other health equity officers, they mentioned, I don't know what success looks like, but I know what it doesn't look like. And that really hit home to be able to track and take time to plan and identify and track what success looks like. And that's also one of the key principles of our strategic plan. And with that, I'd just like to thank you for your time this morning. I know I've covered a lot, and I'm very grateful for the opportunity to share the exciting work around health equity in the National Center for Injury Prevention and Control. And with that, I thank you for all the work you all are contributing to injury and violence prevention. It's been great to be here in Michigan. And if there are any questions, feel free to ask me. Thank you.
Thank you so much for that amazing talk. That was a wonderful way to start us out. I was really struck by your point about eliminating as opposed to decreasing, and your comment about success. Could you, how there's challenges and how you define that, right? And that's important to measure outcome. Just some examples maybe of how y'all plan to measure success.
Yeah, that's a great question. We are still in the early stages of identifying how we are planning to measure success. There's definitely measurement from an internal perspective and taking a look at, we had Policy A in 2019. How have we updated that and changed it, and what impact has it had for our internal staff? And so that's one component that we'll be looking to track and measure internally. But then there's also the external component on looking at how we are working on and tracking various health outcomes, whether that's overdose mortality and morbidity, whether that's various violence prevention outcomes, and how are our programs having a difference in the community. And so we are trying to be intentional about what are the inequities and how do we measure them. And then what does that look like moving forward as we start taking a better look at our surveillance system, start changing what we fund and how we fund things to lead with equity as well.
Thank you so much. I was wondering, I think it's just amazing to hear about these changes and kind of the nuts and bolts of like changing such a big and important institution towards health equity. And I wondered kind of like, what are maybe your visions, maybe what's changed so far, but vision for the future and kind of how the work will change or the funding mechanisms you've mentioned, like what focus do you kind of dream of in terms of increasing that health equity focus?
So many possibilities. As a tangible example, one of the evolutions that we've had, I'll use the overdose data to action example. So, overdose data to action is one of the cooperative agreements from our Division of Overdose Prevention. And the first version of it funded largely state health departments. In this second version of overdose data to action, we've been able to fund both states, but also local jurisdictions. So, thinking of some of the large county and cities who are experiencing disparities around drug overdose burden and being able to fund them. So, that's one direction. And with that cooperative agreement, the writers of that NOFO were very intentional about embedding equity and allowing those local jurisdictions to understand their communities and identify their needs. So those jurisdictions that received funding were charged with performing a community needs assessment to really identify where those gaps are, who are the people, the partners in the community, really getting that landscape and being able to have that as something that's a grant requirement, but pushing that jurisdiction to really go into the community and lead with that community engagement component is one tangible change that we've been able to do. But again, that comes from the perspectives of those NOFO writers and knowing that they wanted to have equity leading forward and being able to meaningfully engage and value the communities that they work with.
Have you had any success finding some strategies for people who may be less excited about equity initiatives than others?
Good question. It is a constant, back and forth with staff. Um, I don't know that we have had a tried and true strategy for us. One of the things that we noticed in some of the data collection processes that we utilize is that when we talked about health equity, or I have a colleague who focuses specifically on DEI and workforce, one of the gaps that we had was the engagement of white men in our center who were not participating on work groups or various councils and contributing to ideas. And so we talked a lot with leadership on how to address that and being able to identify leaders within our center who could provide safe spaces to understand some of the barriers around it. I don't know that we have a tried and true strategy to engage people who are not as excited around equity. What we try to do is tie everything to your individual job, whether you're an evaluator, an epidemiologist, whether you are in management and operations. How are you moving the needle in the conversation to, reduce and eliminate these inequities? Does that look like, taking a look at a different social determinant of health and starting to connect with our program people on what activities could potentially address this? I don't know that we have a right answer, something for us to continue to explore. But we have noted various gaps in engagement with various sectors of our workforce.
Well, Dr. Underwood, again, thank you very much. And let's give another hand. Dr. Underwood, thank you. Please count us in as a center and as a community on extending your reach in your target of eliminating health inequities. Love hearing that. It's been great to have time getting to know you and hearing about the vision that you've introduced at NCIPC, the policies and processes that you've already put in place on DEBIA, and we look forward to continuing to work with you. Our next speaker, I'd like to introduce Dr. Cass Kripasi. Dr. Kripasi is an associate professor at Johns Hopkins University, associate professor of health policy and management in the Bloomberg School of Public Health, and co-director of the Center for Gun Violence Solutions. Her research focuses on the intersection of public health and public safety, including injury epidemiology and prevention, gun violence and policy, and attitudes and public opinion regarding gun violence solutions. Dr. Kripasi, welcome. We look forward to hearing from you.
Thank you for the opportunity to be here today. And I just have to say, I love the poster session this morning. Like, I just love poster sessions. They're so great. You get to connect with so many folks. And so congrats to everyone who had a poster here this morning. So we're going to talk a little bit about epidemiology, the data, the trends, some of the things that we're seeing that are contributing to the problem of gun-related injury and mortality in the U.S. Spend a little bit of time talking about some solutions, because I hate leaving people feeling depressed, like there's nothing that we can do to solve the problem when there are some things we do know, and then save some time for questions. So I'm going to be showing you some data from 2022, some from 2021. I'll try to make it clear what I'm talking about. And you'll see some QR codes in the bottom right. If you are so inclined, you can pull your phone out and scan and go out to sort of the source or the reference there. So as some folks hopefully know, and after today, hopefully you will know for sure, contrary to what we see in the news, on social media, mass shootings are not the leading cause of firearm death in the U.S. It's suicide. In 2022, we had over 48,000 firearm-related deaths, and most of these were the result of suicide. I will say this is down slightly. So 2021 was the highest year ever for firearm mortality. And so we have seen a trend down, which is great. But in 2022, we still saw 27,000 firearm suicides and over 19,000 firearm homicides. And when you look at in Michigan specifically, there were 1,505 firearm deaths in 2022, about 840 or so suicides, and 640 firearm homicides. So this is an important burden where we see the attention and the focus around discussions and solutions often ignoring the primary cause, which is suicide. So when we look at suicide and homicide overall, we see that around 50% of suicides and about 80% of homicides involve a firearm. So that's the lightish dark gray are firearms, and then you can see the distribution with some of these other mechanisms. And one of the reasons for this is that firearms are exceptionally lethal. They are very good at doing what they are designed to do, which is killing the target or severely injuring the target that it's aimed at. And so it's important that we're thinking about that lethality when we're thinking about solutions. It's also important to think about sort of the distribution of mechanisms in suicide. So while only about 6% of suicide attempts involve a firearm, that's that little green wedge up there, compared to like 70% of overdose or poisoning deaths. Because firearms are so lethal, again, we see more than half of suicides in the US involving a firearm, that bigger green wedge there. About 90% of suicide attempts with a firearm result in a fatality, compared to about 10% of all other mechanisms combined. So whether we're thinking about reducing sort of gun violence specifically, or whether we're thinking about reducing the total injury-related fatalities, we need to be thinking about the role of firearms. And just another point about suicide, this has been trending up over the last 15 years. We had seen some stability and some success in reducing firearm-related mortality with particularly suicide, but we've continued to see this trending up, which is concerning when we think about health equity perspective and disparities in this outcome. Some of the highest rates, some of the largest increases we're seeing in young Black populations in the US, and thinking about how we can reach those folks. And I know someone here at University of Michigan is working with young Black youth, trying to engage folks on suicide prevention and identifying some of those risks. But this is a really important concern that is driving up and will continue to drive up our rates of firearm suicide. So while the relative proportion of firearms used in suicide has remained fairly constant around 50%, we're seeing the proportion of firearms used in homicide increasing pretty substantially. So back in 2012, it was around 70% of homicides involving a firearm. And now this is data for 2021, it's over 80%. So it's not just that firearm homicides or homicides are increasing, it's also that they're more commonly used in these interpersonal interactions that are resulting in a fatality. So, and all of this leads to what many of us probably have heard about is this substantial increase that we saw from 2019 to 2021. Again, maybe trending down a little bit in 2022, but we saw about a 21% increase in gun deaths between 2019 and 2021, and this was largely driven by a 35% increase in firearm homicide over that time. You can also see there had been some stability. So between 1999 and 2014, things had been fairly stable. But a couple of things happened in 2014, including fatal interactions between police and community. And as a result, we've seen some sustained increases in firearm homicide. We heard a little bit earlier from Dr. Underwood about the death of George Floyd and some of the social unrest and things related to COVID-19 as well. And we really had this perfect storm coming together that was driving up our rates of gun deaths. Yeah. And this was not just because guns were already out in circulation and being used, but we saw pretty substantial increases in firearm purchasing. I don't know why some of those are a different color, but it's all showing the same thing. NICS checks. NICS stands for the National Instant Criminal Background Check System. And I will note, this is not a direct measure of purchasing because you could undergo one background check and buy one firearm, or you could be in a state where you undergo one background check and you buy 10 firearms. And so this is not a direct measure, but it shows some indication of how people are engaging with the background check system, how they might be engaging with gun shops. So you can see some seasonal variation over time, some spikes, often around hunting season, sometimes around elections. But you start to see a big shift starting in 2008. So for folks who aren't familiar, in 2008, that's when the Supreme Court decided the Heller decision. And this was a challenge to Washington, D.C.'s handgun ban. And for up until the time of the passage of the Second Amendment, all the way through 2008, gun ownership was seen as a collective right. We have a right to firearm ownership. I don't necessarily have a right. And largely that meant that firearm policies, laws, et cetera, were upheld as constitutional. But for the first time in this Heller decision, we saw a right to own firearms for self-defense being added into the interpretation of the Second Amendment. And so there it became an individual right as opposed to a collective one. And if you look at this data, you start to see a trend upward in 2008, again with some of that seasonal variation, as well as spikes following the 2012 Sandy Hook school shooting, the elections when folks were concerned that Hillary Clinton would be elected and implement some major policy changes, up through COVID-19 when we saw some of the greatest gun purchasing happening. And we're really starting to see this play out now in terms of firearm mortality. So between January 2019 and April 2021, we saw around 3% of the US population buy firearms for the first time. So some of these were during COVID, some were not. But that's around 8 million new firearm owners during this very short period of time. And when we think about the exposure to firearms in the home in terms of injury prevention, right, having access to a firearm can increase risk of homicide and suicide for those lethality reasons that we were discussing. We are potentially then seeing the exposure lead to some of these changes in firearm mortality. I'll also note that traditionally, gun owners have been older white males, between 60 and 75% of gun owners, depending on the state. But we saw immense diversification of firearm purchasers during COVID-19. Many more women becoming first-time gun purchasers, minoritized communities, Black communities, Asian American communities, because of concerns around racial violence, hate crimes, were also becoming first-time gun owners. And when you look at the reasons for gun ownership, we've seen some important shifts. 40, 50 years ago, primary reason for firearm ownership was hunting. If you wanted to hunt in public, you had to get a hunting license, which meant you took a hunter safety course. So you at least had some knowledge around safe storage, use, handling. Now we see a shift towards the primary reason, between 70 and 75% of individuals reporting their primary reason for gun ownership being self-defense. And there are no training requirements in most states. Only 3 require some form of training before you can purchase. There are separate training requirements for carrying in public, but very few states require that same kind of training. You have more people buying guns for the first time, bringing them into the home with no requirements for safety training that you may have seen previously. So folks don't know how to safely store them, use them, etc. So taking this graph and just making it by year instead of by month, I wanted to show, again, this sort of relatively stable pattern up until 2008. And then we started to see some of these increases in purchasing. And I wanted to overlay this with that firearm homicide rate. Now, Can we say for sure that changes in purchasing led to changes in homicide rates? No, it's still too early to tell. We need more data to understand whether it's a correlation or if there's some causal piece there. But certainly, as we started to see increases in purchasing, we start to see increases in homicide as well. And so it's important when we think about what the processes are for how people buy guns, how they use them, how they store them. A few more data points just to talk about different populations and their exposure and risk for violence. Guns are the leading cause of death for kids and teens. So we look at age 1 to 19. Over the last decade or so, we've seen an 80% increase in the gun-related death rate among this age group. It's really important. Most of these kids and teens, with some exceptions, can't buy firearms on their own. They're exposed to them in the home with family members or friends bringing them in. But it's important to think about who's at risk, what is the burden among these populations, and how can we think about minimizing some of these harmful exposures while also respecting that there is a constitutional right, and what are those responsibilities that come along with that right. So I also did want to recognize some of the distributions across a few other demographic groups. So first off, I want to recognize that race is a social construct. It's based off of a physical expression of genes, but this expression impacts how people move through the world, the risks they might face, how people interact with them, treat them, et cetera. And so it's important that we understand. But rather than controlling for race in our work, we need to stratify. We need to understand these differential experiences of policy, of programs, et cetera. It's also important to understand how race impacts risk, vulnerability for being involved in violence. And in this graph, you can see that Black Americans experience disproportionately high rates of firearm homicide. Also, we see high rates among American Indians and Alaskan Natives compared to white Americans. And when you look at young people, American Indians and Alaskan Natives have a rate that's almost twice as high as their white counterparts. So I also want to note age. So on the left are white Americans, and on the right is Black Americans stratified by age. This is, again, gun homicide. And you can see, there is some age distribution. Even for white Americans, there are some spikes as folks are in their sort of 15 to 34 age range. But clearly some important disparities that are leading to differences in life expectancy, years of productive life lost when we're looking at the disproportionate burden of gun homicide among young Black Americans compared to young white Americans. As a complement to that, when you look at suicide, we also see some important age distribution. So again, we see some big increases in the teen years that tend to taper off, although are still unacceptably high among Black Americans. And for white Americans, we see that risk increasing over time with the greatest risk among older white Americans. Partly, this is, again, sort of who traditionally has owned firearms, but also we need to be thinking about safe storage, firearm life plans for as individuals age, just like physicians may talk to their patients about when it's time to stop driving. We also may need to start talking with patients about when it's time to store firearms differently or potentially take them out of the home. So it's important to understand there's this common narrative that places like Chicago and Baltimore are responsible for our really high rates of gun death in the US. And if those cities could just fix their problem, then magically we wouldn't have the high rates of gun death that we actually do. But when you graph these gun death rates by state from highest to lowest, you can see that places like Mississippi, Louisiana, New Mexico, Alabama are the places with the highest rates of gun death. So earlier I mentioned Michigan had about 1,500 firearm deaths. And you can see, I put a little red arrow there so you can easily see Michigan if the font is too small, which is about 15 per 100,000 firearm death rate in Michigan, which is just over the national average. But we see huge variation across states. And this is because of the ability for states to choose how they want to regulate firearms. Federal law sets the floor. There's a minimum set of criteria. So you can't be a felon, convicted of a domestic violence misdemeanor, fugitive from justice, involuntarily committed, several others that we could talk about. But federal law really says beyond that, you can do whatever you would like. You can pass additional laws. So, for example, as I mentioned, under federal law, you can't possess a firearm if you're convicted of a domestic violence misdemeanor. But if you're convicted of a violent misdemeanor against pretty much anybody else, most states say it's totally fine for you to have a firearm. So I would argue that being violent towards a family member or intimate partner is probably just as dangerous as being violent towards a stranger in some other location. And thinking about how we can fill that gap. And several states have said we should extend this to other violent misdemeanor prohibitions. But we also see variation in where the guns that are used in crime are coming from. So it's not just sort of the rates of violence, but where the guns are coming from that are contributing to that violence. And we see great variation across states. So in Michigan, I looked up the data for Michigan in 2022. There were just over 10,000 guns recovered in crime. Of those, almost 7,000 or 67% were originally sold in Michigan. The guns recovered in crime in Michigan are very likely to come from Michigan. Compare that to Maryland, for example, which has some additional policies compared to what's here in Michigan. We had around 11,000 guns recovered in crime, but only 3,000 or about 25% came from within Maryland. Now, we still have some high rates of gun violence in Maryland, particularly in Baltimore, but the guns are coming in from out of state, which creates other challenges. How can we work regionally? How can we make the states around us sort of have a higher threshold for purchasing, for private sale transfers, et cetera, to try to minimize the likelihood that guns can make it into Maryland. The only exception is Hawaii. It's an island. It's a lot harder to drive across the border in Hawaii and buy some firearms and bring them in. But for the most part, states with strong laws, they're not their own source for states that are guns that are recovered in crime. But so while this can be disappointing, wow, there are some states that don't have great policy. There are a lot of gun deaths in these states. It also shows us a potential path forward. How can we use policies, programs that are effectively designed and implemented to move the needle in some of these other states? So I'm going to go on a tangent for a minute, and you might be like, what are you talking about? But I promise this will make sense. So we have made immense progress in reducing motor vehicle related fatalities in the US. So you can see the blue line is vehicle miles traveled in the billions with a B. And the red line are the annual deaths per billion miles driven. So we are driving many, many, many more vehicle miles every year, but we have effectively reduced our motor vehicle crash rate substantially. And we didn't do it by banning cars as much as I would love it. I love walking everywhere. Doug and I were like all over campus yesterday. It was great. I would walk all the time if I could. No, we did it because we made roads safer. We made them easier to navigate, easier to follow the signs. We developed safety technologies in cars. We improved driver skills through training. And again, as a result, we see lots more driving, way less mortality. So I have a question. How many people saw a car today? How many people saw a firearm today in person, like actually saw a firearm in person? Yeah, so nobody, just for the people in the front. So nobody saw a firearm in the room today. But in 2022, we had around 3,500 more firearm-related deaths than we did motor vehicle crash-related deaths. So clearly there are things that we can do, we can learn from motor vehicle safety. So I'm trained as an injury epidemiologist. My favorite thing are the 4 E's, right? Education, can we teach people? Driver training, firearm safety training, can we teach people to do the safe thing? Engineering, can we design the places, the products to be safer, right? A core lesson I learned is if we can make the safest thing the easiest thing, people are more likely to do it. Enforcement, so if people are following their training or they're not designing products in the right way, can we hold people accountable for that? And how can we use economic incentives to encourage the kinds of behaviors we want to see or discourage the kinds that we don't want to see. So could we give tax incentives when you purchase safe storage devices? That way we make them more accessible. And when you have them in the home, you're more likely to use them than if you don't have them in the home. But really thinking about the core tools that we have available to us in injury prevention and taking them to the same strategy with firearm prevention. Again, not about necessarily taking everybody's guns away, but how can we have better policy? How might we design better products, whether that's storage devices or the firearms themselves, to make it less likely that firearms would be used to harm someone or others. Okay, so I want to come back here for just a minute, again, just to say there's a clear pattern, right? We see states with the weakest gun laws, or if you want to go the opposite direction, the states that tout themselves as being most gun friendly, we see them on the left side with the highest rates of gun death. The states with the strongest laws, or those that, various outlets might say are least gun friendly, we see the lowest rates. And so how can we learn from this graph? Now, anyone who says if you take the laws in one state and just magically apply them to another state and boom, you save all these lives, sort of ignores the context of gun ownership, the gun ownership rates, et cetera. So there's no magic solution that is going to dramatically drop our gun death rates. But California used to have some of the highest gun death rates in the country. And in the 90s, they passed several policies, record keeping and background check and sales requirements, and they dropped their firearm death rates remarkably. So now they're over on the right-hand side because they put these policies in place. It took time and it took effective implementation and funding, but there's work that states can do. So what are those things? And so with the last couple of minutes, I want to just highlight some of the policies that our center really focuses on. Again, you can scan that QR code to go out to our website to get more information. So one of the core policies we're focused on is the public carry of firearms. So if folks aren't familiar, several states had a type of policy that said you meet some objective criteria, but then you also need a good and substantial reason to carry a firearm around in public. You couldn't just say a nebulous self-defense reason, you had to have some good reason. And that was struck down in a challenge to New York's law in the summer of 2022. And they said, you can have licensing, but you can't have discretion. It did some other things too, which we can talk about, but I'm just going to focus on this piece for a moment. And so in anticipation of that law coming down or that decision coming down, we had been evaluating what are the important components of concealed carry systems that might minimize some of the harm. So is it really the discretionary piece that's important, or might it be who can get a concealed carry license or what the training requires? And we found that states that have live fire as part of their training and that prohibit violent misdemeanors from getting a concealed carry license didn't see the same substantial harms when they lost discretion as states that had those pieces in place. And so this is a really important way to show here are some objective pieces that states could put into place to help minimize the harms with making it easier for people to carry firearms in public. Community violence intervention is a really important piece of work that we do, which is sort of a very nebulous statement that means a whole bunch of things to different people. But for us, this really means how can we make sure that we are engaging with community to identify and understand their preferred solutions and help get those solutions put into place. So some of this is traditional community violence intervention, violence interruption, connection to social services, peer mentoring, transitional jobs, transitional housing, et cetera. But this also includes things like cleaning and greening and demolishing vacant buildings, and a program that we've developed, Violence Reduction Councils, which brings a public health approach to public safety data, including bringing in the voices of community to help co-create the solutions that they're interested in seeing. Safe and secure firearm storage is a really important piece. So as I mentioned earlier, we see unacceptably high rates of death among kids and teens. These kids cannot buy guns themselves. They're getting them from within the home. So how can we promote, again, those responsible behaviors that we want to see not just focusing on the rights. So one of the programs we have is a screening and brief intervention program with adolescent patients and adult patients in the trauma center, identifying whether they have access to firearms, using a motivational interviewing tool to encourage them to engage in safe storage behaviors, addressing barriers that they may have, and providing them with high quality locks or lock boxes to try to promote those kinds of behaviors. We also focus a lot on firearm removal laws. So this includes extreme risk protection orders and domestic violence protection order removal. And really thinking about strong policies that regulate who can buy firearms. But we often have people who lawfully bought them, who lawfully own them, and for one reason or another, go through a time of crisis or other elevated risk that makes them, it's unsafe for them to have firearms, at least temporarily. And really building off of the domestic violence protection order process, having a court-ordered process that allows for due process and presenting of evidence to petition the court to temporarily separate someone from their firearms and keep them from buying more for the duration of the order. And this really thinks about how can we not just restrict access to lethal means during a time of crisis, but how can we connect people with services? When we think again back to our core tenets of injury prevention, one of Haddon's main principles is separating in time and space the harm from that which is to be protected. So how can we separate those individuals who are elevated risk from accessing firearms? And we know that even if individuals were to opt into a different mechanism, the case fatality rate is so much lower that if we can limit access to exceptionally lethal means such as firearms, we may limit the likelihood that an individual will die from suicide during the time that they are subject to an extreme risk protection order. And then the last policy that I want to highlight, I'm going to spend just a little bit more time talking about this policy, is one that I have spent most of my career focusing on. Sometimes it's referred to as permit to purchase laws or firearm purchase or licensing laws. And this is about addressing weaknesses in the federal background check system. So under federal law, you only have to undergo a background check from a licensed dealer. You fill out your 4473, they submit it into the NICS system. If that check doesn't come back within 3 business days, the default is that you can sell the gun to that person, even if they might be prohibited. Around 5,000 times per year, people who should not legally be allowed to buy firearms get them lawfully from a licensed dealer because the incentive for the dealer is to sell the firearm. And there's no recourse if they do it because the default is to proceed. Then we're spending resources and exposing individuals to risk by having to go then disarm somebody who shouldn't have had one in the first place. So what permit to purchase laws do is they have a more robust background check, accessing state, local, and federal records, because sometimes there are delays. Government isn't always good at talking with other levels of government or with each other, even federally. And so thinking about how can we access records that might not yet be reported into the NICS system, using a fingerprint-based background check. Because it turns out if all you use is demographic information, you miss about 12% of prohibiting conditions. That's why if you want to be a teacher, a healthcare provider, other kind of person that may be working with sensitive groups, you have to undergo a fingerprint-based background check. They want to make sure that you don't have a prohibiting condition. And so this strengthens the quality of the background check. And law enforcement has more time. On average, up to 30 days. Doesn't always take that long, but much more time. And then you can't buy a firearm if you don't have that valid license. So it closes a lot of those weaknesses that we have in federal law. And we've done cross-sectional work, quasi-experimental work, really trying to understand the relationship between these policies and various outcomes. And our work and the work of other centers have found that these laws are associated with reduction in homicide, suicide, shootings by police, diversions of guns for use in crime, a whole range of outcomes, mass shootings as well. So it's really about how can we make sure that people who shouldn't have firearms don't get them, and how can we have these robust policies in place? So that's all I have. So happy to take Q&A, and I'll just put up here my contact information in case anyone wants to reach out.
Hi, I'm curious, the
the 87% increase in children and youth fatalities, what correlation is there, if any, related to like school shootings? Or do you have any thoughts about data related to that?
So small, very little. So when you look at the total proportion of gun deaths, maybe 2% or less are related to sort of mass shooting events. So it's unlikely that that's directly contributing. Not that they're not important and not that we shouldn't focus on them, but there are other important things: loneliness, disconnection. Individuals spending a lot of time in social media and sort of doing some of those comparisons. So there are some other probably more social challenges there, and then like you can't have a gun death if you don't have a gun. And so certainly all this expanding exposure over the last decade has been important.
My other question, I think today is the first day in my life I've heard the term injury epidemiologist. And I'm curious sort of if you could talk at a high level about your trajectory to how you got to where you are now.
Yeah, absolutely. So injury epidemiology is really just applying all those epidemiological tools to study injury. Distribution, causal inference methods, et cetera. I have told the story to a couple of people. I was a failed medical applicant. So I wanted to be an orthopedic surgeon. Thought it was really cool to fix people after they were hurt. Didn't get in. Was referred to public health and thought, I'll do this because it'll definitely get me into medical school. And then, the first week of class, heard a lecture from Dr. Jennifer Taylor at Drexel on injury prevention. It was like, you can keep people from getting hurt in the first place. That was like not a thing I had ever been exposed to. And so that really sort of shifted my training and thinking about how can we understand the role of policy to advance health promotion, sort of get population level protective benefits. I do programmatic work as well, but really thinking about how we can understand how policy influences the distribution of injuries and violence. That was really sort of what set me off on that path. Yeah. See, it's all about leaning into the silence. You got to give people a moment to like gather their thoughts.
Thanks for that. Great talk. I had a question about the economic incentives you talked about. So especially with the older population, you're saying as they're getting older, maybe it's a physician decision to take guns away. But are there like gun buyback laws from the states that make it not that because you're at risk, but it's that maybe you bought one, but you don't feel the need to have one?
Yeah, so this is something we've been talking a lot about lately because, again, so many millions of people bought firearms. They were concerned around COVID, uncertainty. If I'm stockpiling my resources and somebody has a gun, are they going to come take my resources away? So there are a lot of concerns around that. So a lot of people bought firearms, and what do they do with them now? And I know, as Doug mentioned, David Humphreys is here looking at some of these, how you get rid of firearms you don't want anymore. Very specifically about gun buybacks, I will say the evidence is really mixed for two reasons. One, the types of firearms that are often turned in gun buybacks are usually not the kind that are being used in crime. So when we know the type of firearm that's used, about 90% of them are handguns. We hear a lot about semi-automatic rifles, and certainly when they're used in mass shooting incidents, we see higher rates of casualties, more people shot. But they're not commonly used in other types of crime and violence. They're just harder to carry around. And so we tend to not see the semi-automatic handguns being turned in. The other unintended consequence, and again, there's some mixed evidence on this, is that often in places that are doing a gun buyback, because there's usually no questions asked for the gun buyback, you see household theft from autos spiking in the lead up because people will go steal firearms and turn them in. Which is not exactly what we would want to see. But, there are other ways that we might think about how we can handle unwanted firearms. So when there are estate transfers or, again, the University of Colorado has done amazing work with a firearm life plan. So as a firearm owner, what do you want to happen to your firearm if you were to die in, before you were planning on it? Not that anybody plans on that. That wasn't worded quite right. Anyway, you get my point. Or like, what do you want to do with your firearms if you get diagnosed with dementia or other sort of health issue? And how can we better plan? Again, a lot of my work comes back to, we are very quick to talk about the right of firearm ownership. And we are like way ignoring all the responsibilities that come along with that. And how can we reorient the conversation to think about, okay, you choose to have a firearm in your home. What are the things that you need to do as a result? I personally think the insurance industry runs the world. And so if there's some way we could engage with the insurance industry to think about different kinds of fees or tax breaks or whatever that we could work into it to try to figure out how can we, again, encourage the kinds of behaviors that we want to see.
Hi, thank you for that presentation. Have you seen, you talked about semi-automatic and handguns. Have you seen changes in ownership in that regard? Like, is there more people owning semi-automatics now, or the types of pistols, are there now more 9mm versus, is that market dynamics have really changed in the US? And are there good sources out there about firearm ownership? I see some figures out there, but are they reliable?
Yeah. I'll answer your second question first. So RAND has their great firearm ownership rates, but those only go through 2016. But I do know they're working with a lot of folks who do national survey research. So I do a lot of public opinion polling. We always ask people, do you personally own firearms? So we have lots of measures of nationally representative samples, but you pool enough of them together and you can get some state estimates. So they're working on updating that now. So RAND is great. There are problems with the traditional proxy that we've used. So the ratio of firearm suicide to all suicide. One, if you're evaluating suicide and then you have your proxy and then you have both, things on both sides of the equation, which is problematic. But so that's great. The other thing that folks are moving towards is FFL density. So federal firearm licensee density, because where there are more shops, there are likely to be more people buying them. Otherwise, why are there so many licensees? To your first question, I actually had a slide in here that I pulled out because I didn't think I would have enough time. But there has been a huge shift in manufacturing. So if you look back even just to 2000, there's a pretty relatively even mix of revolvers, shotguns, rifles of all kinds, and then pistols, which are semi-automatic. In around 2008 to 2010, you see a huge jump in the manufacture of semi-automatic pistols, right? Again, they're not going to make them if people aren't wanting to purchase them. So we see a big jump, which again correlates with the sort of self-defensive perspective of firearm ownership. But you also see really substantial increases in rifle production. And again, we don't have sort of a direct causation, but I expect that the lapse of the assault weapons ban in 2004 contributed to the increase in rifle production, again, as it became a lot easier to purchase semi-automatic rifles. That's really what we think is driving the increased rifle production. And they, think about oh, wow, I almost tripped. So here, like this would be revolvers and shotguns. And then you see semi-automatic pistols and rifles, like a really substantial difference, which again, if you're not buying guns for hunting, you're buying them for self-defense, you're going to buy the types of firearms that you perceive to be self-defensive firearms. There's one in the back.
Thank you. Hi, good morning. I'm wondering, what role does white supremacy play in the uptick of just more guns proliferating?
It's such a great question. And it's an important topic that we work on in our center. If folks are interested, we just released a report, Defending Democracy, that talks a lot about political violence and white supremacy and the role of firearms in suppressing sort of First Amendment expression. But also thinking about concerns around racial and political violence. So our most recent public opinion poll that we did in 2023, we asked people, did you buy a gun for the first time since the beginning of the COVID-19 pandemic, so January 1st, 2020? And we asked them if that purchase was motivated by concerns of racial violence or concerns of political violence. And people who bought guns for the first time during the COVID-19 pandemic compared to people who either already owned guns and didn't buy new ones or already owned guns and did buy more. But these new gun owners, these first-time gun owners, were between 3 and 5 times more likely to say that that purchase was motivated by concerns of racial or political violence. And what that means for different respondents is different, obviously, right? If you are a respondent from a minoritized community, concerns around racial violence may be very different than if you are from the majority community responding to concerns around racial and political violence. But there's some really great work also coming out of Garen Wintermuth's group at UC Davis, looking at the acceptability of using violence to achieve political aims and really advancing sort of white supremacist ideals in the US and really retaining that majority control. So it's a really important component that honestly not enough folks have been paying attention to.
Thank you. That was a phenomenal presentation. I was wondering if you could speak a little bit more to like the interface of your work with policy. I'm sure you approach that very intentionally. Can you speak more about that process? Do you work with policymakers?
Yeah, so we do a lot of work with policymakers. So I'm trained in public health. And if you know the public health model, the fourth step is ensuring widespread implementation and scale up of the work that we're doing, which to me is advocacy. If people don't know about your work, they're not going to implement it and you're not going to see that success. And so we do a lot of work with policymakers, local, state, and federal policymakers, but it's sort of a bi-directional relationship. So some of the most rewarding and interesting questions I've answered were things that policymakers or local communities were asking. And then we said, well, we don't know. Let's go find the answer. But really thinking about how can we educate people, whether it's the policymakers, the community folks that they may be interacting with, to make sure that they have whatever information that they need. And this comes back to effective communication and dissemination. As much as I would like to think that everybody reads every paper that I published, probably unlikely. So how do we translate that into an infographic or a fact sheet to really make sure that we can reach the people who can use the information? And sometimes that includes our center actually formally endorsing a policy, because based on our research and other research, we think that this would be good for public safety, good for public health. And that process includes using a tool that we developed called Racial Equity Impact Assessment. So we have a series of questions that we answer. Is this going to exacerbate existing racial disparities? How might we sort of fix the language of the policy or suggest recommendations that might minimize the likelihoods that those would happen? How do we engage communities who are going to be experiencing this policy to make sure that it's not just, a law being applied to them without them having an opportunity to have input? Because as a researcher at Johns Hopkins, I have a unique privilege to be able to be in these rooms, have these conversations that a lot of folks don't have the opportunity to do. And so it's my job, part of my job, an important part, to make sure that I'm bringing in those voices, bringing the people in when I have the chance, but at a minimum, making sure that folks who are making these decisions are thinking about beyond just the common narratives that they're hearing, and what do we need to address to make sure that we can really reduce whatever the problem is and not make things worse, because we're not always good at unintended consequence sort of anticipation.
You asked the right person. Dr. Kapasi, we're so fortunate to have you here. Thank you. Thank you for your injury epidemiology. We're so glad and fortunate as a field to have you focused on firearms. Love the way that you tie it to policy. Love the 4Es. Love the analog to motor vehicle crash. Thank you for motivating us and keeping us optimistic about the great opportunities that we have to further pull levers to make a bigger and bigger dent and work on reducing the impact of firearm burdens in the country. Could I ask both of you briefly to come up? We have a little something for our 2 keynote speakers to take home. And inside the box, as we do at University of Michigan, we may be sending you home with some Michigan-esque gear.
Other than the folder,
Really
for you.
Southern Michigan.
Here it is. I don't know the extent to which it's welcome in a UGA home. You can keep it at the workplace if you need to, but yeah, we hope that you remember us fondly. We thank you for your time here. Everyone, it is break time. Please enjoy snacks, posters again, and already at 10 after 11, we'll be back for Flash Science, and we'll keep the pace going. Thank you. Enjoy your break.
Thank you so much for joining us for this afternoon session, or I guess late morning. My name is Maureen Walton. I'm a professor in the Department of Psychiatry. I'm also the Senior Associate Director of the of Research for the Injury Prevention Center at Michigan, and I also have a role at the Addiction Center in Psychiatry. So I'm delighted to be here with you today to introduce our speakers for our Flash Science session. I'm going to introduce each speaker, and after each speaker, they will do their presentation for 10 minutes, and then we'll have about 5 minutes for Q&A. So to start, I am so excited to welcome Dr. Sarah Pietzmeyer. She's an assistant professor at the University of Michigan in the School of Nursing and the School of Public Health. She will be speaking about adapting an evidence-based sexual assault prevention intervention for women undergraduates for hybrid in-person online delivery. Thank you, Sarah. If we could have a round of applause.
Thank you, everyone, for being here today. I'm so excited to talk about our intervention. So echoing a theme from Dr. Kripasi's talk, sometimes people are surprised that we actually have interventions that work to prevent violence. Like we already have ones that work. So one such intervention for sexual violence on college campuses is called EAAA, or Flip the Script. This was developed by Charlene Sen at the University of Windsor. You can see a snapshot from their New England Journal of Medicine article showing that women in college campuses who took this program were half as likely to be sexually assaulted in the year after they took the intervention. They actually followed women over 2 years and saw sustained reductions in sexual violence over that time period. So we have interventions that can actually cut sexual violence in half on college campuses, which is really exciting. The way that this intervention works is it's a 12-hour group learning intervention for freshmen and sophomore women. The first unit is called Assess. And so the idea behind this unit is that we're so taught to fear the stranger in the bushes that it's actually can be difficult to recognize what coercion looks like from people that we know and maybe even care about, right? So actually learning how to assess risk and recognize coercion in an evidence-based way. The second unit is Acknowledge, and that is where we unpick a lifetime of female gender socialization in 3 hours. So we talk about messages that we have received about, oh, maybe he just didn't understand, you're being paranoid. Also, like, be nice, don't make a scene, all of those things that actually inhibit us from recognizing and resisting coercion when it's happening to us. Unpacking all of those and affirming that we have a right to protect our own safety. ACT is the third unit. And so that really helps expand women's toolbox of options for how to respond once they have recognized that coercion or assault is happening to them. And so that includes instruction in forceful verbal and physical self-defense instruction. And that's because research evidence that shows that that is actually the most effective way to reduce your risk of completed assault without increasing your risk of injury. And the last unit, which I really love that we end on this, is a sex-positive sex ed unit. And so this is, giving 18, 19-year-old women a space to actually think about what they want. And a lot of these young women have never been given that opportunity to consider for themselves what they actually want for themselves. And that really helps reinforce some of the lessons from previously about, we have a right to pursue the sex that we do want to have with consenting partners, as well as resist the sex and refuse the sex that we do not want. So, despite the fact that this program has been shown in a randomized controlled trial to cut sexual violence in half for college women, the problem is implementation. And this is a very intensive intervention to implement. And thus, only a handful of colleges in Canada and the US have actually implemented this intervention. Michigan has tried a couple times and never quite managed to go and get trained and bring that knowledge back to campus. So a lot of colleges, it's just too logistically burdensome to actually get this evidence-based intervention implemented on your campus. And campuses just don't want to take on being the implementers of this intensive intervention. And so Charlene Sen, who developed this intervention, and I had the idea, what if we could take this intervention online? And that would from an implementation science perspective, really change how this intervention could be rolled out. If it happens online, then we could have a centralized pool of facilitators that are trained by a nonprofit organization. And then those women could, zoom out to colleges across Canada and the US and maybe elsewhere and deliver the intervention to any women who are interested on any college campus in joining this program, right? And so now every individual college doesn't have to become an expert in this intervention in order to bring it home to their campus. So the Injury Prevention Center here funded our pilot study. And so we called this Adapted Intervention, Internet Delivered EAAA, or IDEA Cubed. We used ADAPTED, which is a systematic intervention adaptation framework, to make sure that we were, maintaining the effective core elements of the original intervention while moving it online. We had a process of piloting the intervention in 5 groups of women and iteratively revising the manuals and retraining facilitators each time as we kept improving the online adaptation. We collected information on acceptability through both focus groups and surveys with participants. And we also collected some preliminary information on potential efficacy of the program. So we knew, because there was this randomized control trial data of the in-person intervention, we actually knew what were the key mediators of intervention efficacy of the original intervention. The primary one was self-defense, self-efficacy. So increasing women's belief that they could defend themselves if necessary in a sexual assault situation from someone that they knew was what was the primary driver of intervention effect in reducing sexual assault victimization. So we looked at pre-test, post-test changes in that construct, as well as we looked for reductions in rape myth acceptance, belief that women are the cause of rape, and increases in women's belief that they could be at risk of sexual assault, because the belief that sexual assault is something that only happens to other women who are doing something wrong is something that actually also inhibits our ability to recognize and resist coercion. So these were all shown in the randomized trial data to be validated mediators of intervention effects. We looked at pre-test, post-test changes in these constructs. So this is what it looks like in the pilot. We ended up with a hybrid in-person online delivery. So what this looked like is that women came with a friend, or we paired them up with someone if they didn't have someone already. And those 2 people met in person, and each pair zoomed into the intervention together. So the facilitators are never in the same room as the women in the program, but you do have one in-person buddy. And this ended up really blending the benefits of in-person delivery. You have that camaraderie with your in-person partner, but it had all the implementation benefits of online delivery, right? Because we can still centralize facilitation and all of those pieces. So in the middle top row, those are our 2 facilitators who are looking on during the ACT unit, looking for safety as women are practicing some physical self-defense techniques with their in-person partner. So they still have the ability to have that in-person interaction while having all these remote implementation benefits. All of the activities, this is a very interactive intervention, were adapted for the online space. So this is an example from the sex ed unit, as you can probably guess. At the beginning in the in-person, there's an activity where there's like big Post-it notes or whiteboards around the room where you go around and write slang terms that you know for different body parts or sex acts. And so for the online version, we use Google Jamboards to do all of that virtually. And women reported really enjoying this, that we still have this interactive component that they got really into all of it. So what were our pilot results? We had 72 women in our pilot trial. 8.5 out of 10 on average for how much would you recommend today's session for a friend. I think this is really good for a 3-hour Zoom call, right? On either your weekday night or your weekend afternoon. And you can see from some of the focus group data that, when asked what did they like about the intervention, they were saying the most important thing for me was doing it with a partner in person. And so that hybrid online in-person, where it blended all the benefits of in-person delivery for participants while maintaining the benefits for us as the implementers of online delivery, really worked well for participants. And you can see at the end, they said, we were all having fun with each other. If you've ever taken a sexual assault education workshop, most people don't come out of it saying it was really fun. And I'm really proud of that with our intervention, that women are really enjoying this and getting a lot out of this experience. Looking at those pre-test, post-test changes in those validated mediators of intervention effects, you can see that there's that jump in self-defense, self-efficacy. The magnitude of that change pre-test to post-test is similar to what was observed in the in-person randomized trial. So that was really encouraging. And then the scale doesn't look very impressive for the other mediators because those those constructs are on a different scale, but we also saw significant changes in the correct direction for decreases in rape myth acceptance, decreases in belief in that women cause rape, and increases in perceived risk of acquaintance rape. So that was exactly what we wanted to see, which was really exciting. So building off of our results from this Injury Prevention Center pilot trial, we have been doing a Canadian Institutes of Health Research funded randomized control trial at 4 sites. So we have Michigan and University of Nebraska are 2 U.S. sites, and then University of Windsor, which is just across the border, 45 minutes away from here, and then Guelph, which is outside of Toronto, are 2 Canadian sites. So we hope to enroll about 2,000 women over 3 years. We're randomizing women to either receive this adapted intervention or a 1-hour consent workshop that has the same hybrid online in-person format where you join with a friend, you show up on day 1 and find out which group you're in. And we're following women over 1 year to see if we can actually observe reductions in sexual assault victimization. So far, we kind of had a soft launch at the end of last semester and are halfway through our recruitment for this semester. We have about 212 women who have been enrolled and randomized into the project. So far, we're kind of on par with what we saw in the pilot, 8.3 out of 10 for how much did you enjoy today's session, and 8.8 out of 10 for how likely are you to recommend the program to a friend, which I think, again, is really good for a 3-hour Zoom session, right? In terms of implementation lessons, for those who are thinking about maybe, can my intervention do a hybrid online in-person adaptation to increase implementation? I would say we've seen a lot of pros just even in the trial, more nimble implementation. So sometimes, we had planned to run a group at one campus, but we only managed to enroll 4 women. No problem. We just combined it with a group at another campus that was running, that we had planned to run at the same time. And now we have women from Nebraska and Guelph in the same group together, no problem. We just send them the same Zoom link instead of 2 different Zoom links, right? So that makes it really easy on the implementation side. Similarly, much easier to swap out facilitators. We had a facilitator who got sick, and no problem, because we have a centralized pool of facilitators. We can just swap somebody else in, compared to the in-person version of the program where you only have maybe 2 or 3 pure facilitators that you've trained on your campus. There is no one else to swap in, right? So from an implementation standpoint, it's been really great. And participants really report enjoying the hybrid online in-person as well in this trial. They really like that they get that close bond with having a partner that they're with the whole time, while still really enjoying those virtual interactive activities. Some cons to this implementation model: we did have to add a 3rd tech facilitator after the pilot. So in the pilot, we just had 2 peer facilitators, and that's how the in-person version is run. Our facilitators did an amazing job, but they were it was so stressful having to manage the breakout rooms and the apps and all this stuff, screen sharing. So now we have a 3rd person who is doesn't require as much training, but they're there to handle all of those tech pieces and take that cognitive load off of the facilitator so they can do what they do best in terms of facilitating rich discussions and building, group camaraderie, delivering the content of the intervention. We have had 1 or 2 problematic participants. This basically never happens in the in-person because it's hard to act up when you're in a room together. We have had 1 or 2 participants who are, giving troll answers in the sex ed unit or that kind of thing, and where I think there's a little bit less peer pressure when you're in a Zoom group instead of an in-person group. So we have had that pop up a little bit, but it hasn't been unmanageable. And then the other piece is that once we pair women together and they show up for the intervention, no problem with the partnerships, and they really like meeting new women and getting to know them. But in the enrollment phase, sometimes there's one person that we pair up with someone else. One partner is really excited about the study. The other person's kind of in it for the money, but they're on the fence. They're not really they're not that committed. And so sometimes that person will drop out. We'll have to repair them with someone else. So that has been a little bit of a challenge in terms of pairing people up. So we're really hoping that this is shown to be effective in this randomized controlled trial. And theoretically, it would be, the first evidence-based intervention that can be delivered online to reduce sexual assault victimization on college campuses. We hope this is really way more scalable and cost-effective than existing version of this intervention that's in person. And it's also really exciting to think about future adaptation possibilities. So because now no longer colleges are the implementer, now we have a centralized implementation, we can think about adapting this program for minority populations. So my interest is really, I do a lot of work in LGBTQ health. in the process of trying to adapt this intervention for trans students. So if you think about the in-person version, colleges are unwilling to invest in, implementing this program for cisgender women on their campuses. They're unlikely to invest in training trans peer facilitators to run very small groups of trans student programs, right? But if we have centralized implementation where students from many campuses can join the same group together, colleges no longer have to train people themselves, hire people themselves, supervise people themselves. We have the centralized facilitation. We now can have groups of trans students from across the country join in one group together, and it makes the implementation piece so much more feasible. And if you think about it, colleges are no longer the implementers. That also opens up a world of possibilities for non-college populations who might benefit from a version of this program, right? So we know that community-based samples of women who are the same age as college women actually may be at more risk of sexual violence than their college peers. So how do we continue to adapt this intervention to help other groups of women and other folks who may benefit from it? So thank you.
So I appreciated the sort of risk assessment piece, and I'm wondering what you've learned from this pilot and what you're doing now with this project. How can you translate that risk assessment out to the broader population beyond just engaging in this program? Like, are there lessons that you've learned, things that really resonate that you might be able to translate out to the population?
Yeah, so that first unit about like how do you actually recognize what coercion and assault looks like? Yeah, a lot of the principles are the same. So again, we're sort of taught to fear like dark parking garages, stranger in the bushes, rapists are these crazy people on the margins of society. And we're not taught to recognize that like, oh, actually sexual assault often comes from men that we know, boyfriends, friends, a guy in your class that you study with, what have you, someone you met at a party. So that piece around like folk acquaintances and intimate partners are the most likely perpetrators of sexual assault holds true for community samples as well as trans and gender diverse folks. So a lot of those pieces are the same as we think about different specific adaptations. For instance, for the trans and gender expansive adaptation, actually talking about how do we recognize coercion? So what are specific coercion tactics that people use against trans and gender diverse people? So belittling or attacking them on the basis of their gender, saying no one else will ever want to be with you but me because you're transgender. A real man or a real woman would have sex in this way. So those specifics for different populations that really help people be like, oh, like if I'm hearing this, that's actually like a sign that someone is wearing down my boundaries, trying to coerce me into maybe doing something I don't want to do, and recognizing what that actually looks like and having a space to talk those things through is really helpful.
Thank you so much, Dr. Pietzmeyer. That was really incredible. Our next speaker is Dr. Christy Gamaral, is an associate professor and associate chair in the Department of Health Behavior and Health Education at the University of Michigan School of Public Health. And her presentation is titled, Because We Grew Up in It, Findings from the Triggered Project, Examining Gun Violence Exposure Among LGBTQ+ Adolescents and Young Adults of Color in Detroit.
Thank you so much. All right, so I am going to do my best to do a flash 10-minute talk. So I'm going to even put my timer on because presenting is challenging in 10 minutes. But I want to thank you all for being here. I am Christy Gamrell, she, her pronouns. I am, just to know who I am, and my positionality, I am a white queer woman. I actually grew up in the suburbs of New Jersey. And so I think that's important in terms of thinking about who I am presenting this work. So because we grew up in it, we had the wonderful fortune, a lot of our work focuses on violence prevention with trans women of color in Detroit, as well as addressing structural vulnerabilities. And as IFIP was being developed, we had this opportunity to think about what does gun violence look like among LGBTQ plus folks of color in Detroit. And so this is not new to anybody in this room, and this echoes a lot of what has been said. That gun violence and firearm violence is a significant public health concern. We've heard some incredible talks this morning highlighting the importance, but it's also an important concern for LGBTQ plus communities. We have very poor data to support those claims, but we know that is the case. We have terrible surveillance and data collection about this, and this is an area that I hope we can improve. But gun violences have been identified as being used in nearly 60% of biased, motivated hate crimes against the LGBTQ community. We also know from cross-sectional studies that LGBTQ people have a higher prevalence of suicide ideation, attempts, IPV, and other forms of violence and discrimination compared to their non-LGBTQ plus counterparts. What we don't know, and what there's been a limited focus on, is the experiences of gun violence among LGBTQ plus young youth and young adults of color. And so our lofty presentation aims, which I'm going to brush through quickly, are to describe in participants' experiences, their experiences of gun violence, to identify what they described was the potential causes of gun violence exposure, and to explore what they thought in their own words were areas for future prevention efforts. And so this is the incredible team that I work with, and I could spend the entire time talking about them. But we are a diverse group who bring a lot of different perspectives to this work. And so it's been an honor to work with them. So in terms of our methods, this was primarily a qualitative study. As you all know, presenting qualitative data in a lightning talk is a challenge. I will do my best. But we also included a brief survey. And notably, we had a really thoughtful and informed wellness check with our participants. So the analyses that we used were reflective thematic analyses, which allowed us to think about things both deductively and inductively. So who were our participants? Well, they ranged in age from 18 to 29. So they were emerging adults who on average were 25. You can see that the majority of our participants identified as Black or African American. There was diversity in terms of participants' sexual orientation. And in terms of gender identity, we also had diversity as well. You can see here that the majority of the participants that we spoke to identified as trans women and cisgender men. And we also were able to enroll and reach trans men and folks who identified as Two-Spirit. So quantitatively in the survey, we did ask about people's experiences of gun violence. And you can see here that there's a tremendous amount of exposure to gun violence, where 52% had carried a gun, 63% of our sample had shot a gun, and 81%, just to note, had a friend who had been harmed by a gun. So these numbers are quite staggering. The other thing to just note is that suicide ideation with a gun and suicide attempt was quite low. And this mirrors a little bit with what was shared with us earlier when we think about those intersections with race. We also included the community violence measure that has been used in many of the Flint studies. And so you can see here that there was a tremendous amount also of community violence, experience of violence that young people were encountering in their communities. So seeing someone shot by a gun, seeing gangs, you can see all that. So the qualitative portion, which is the real heart of this, what we found was the causes that participants identified was intersectional, and they were structural in nature. So the intersections between, in particular, anti-Black racism, poverty, and anti-LGBTQ plus stigma were described as fundamental root causes of exposure to gun violence among participants that we spoke to. And this was at the backdrop of the context of gun violence in the United States that we've heard so much about today, and how this contributed to exposure to multi-layered gun violence. And so the young people that we spoke to, they had grown up with guns in their lives at such a young age. We asked, when did you first experience a gun? People grew up with them at such a young age, 5, 6, being exposed to neighborhood violence, gun violence in schools. They live in economic deprived communities in which there's a lot of carjackings and robberies. And so this exposure to multi-level gun violence was most eloquently stated by this young man who said, "I feel like because we've grown up at it, it's almost like in a sad way we're all prepared to die." At a point when it comes down to someone like, I've had a person pull a gun on me before, so I think we have to come to terms of it's what it is. So it forces you to live in the now and kind of you hope for more and better, but you never know what life will throw your way. And this statement really resonated with us. And when we asked participants the causes, their narratives were very much rooted in systemic racism, things that we've heard about earlier today. As one woman shared with us, I think the cause of gun violence in our communities is systemic racism. That is the white man in power that's developing certain neighborhoods and zoning laws and blocking off certain neighborhoods. If you put a bunch of mice in one specific area, but you don't give them enough food, you don't give them enough resources, of course, they're going to attack each other. Of course, it's going to be some type of issue going on because, for one, it's systemic racism. And this quote really resonated to the extent to which anti-Black racism and the history of racism within Detroit and many urban areas was very present for the young people we spoke with, and how this was interlaid with and intersected with being an LGBTQ plus young person, in which incredible discrimination exists in school systems, employment settings, and how that contributes to incredible poverty. And so this intersections led, as one participant shared with us, just like a lot of people do sex work, a lot of people are scammers. The occupation level in Detroit is not very high. But it's a dangerous field of work because I know some people engage in sex work because they think it's necessary. So that's just a tricky thing to say. All right, well, we could just stop working and this gun violence wouldn't happen. But what else would they do, right? So thinking about this interplay. And then participants really spoke about the gun violence and the homicides of Black trans women in particular. And speaking about the ways in which this homicides are perpetuated out of hegemonic masculinity and hate against the LGBT community. And so, as one woman said, where in the LGBT community, there are a lot of guys that could meet up with a trans woman, and after they slept together, hung out together, he felt like he had to erase her. I mean, they feel like, oh, you're going to go tell my friends that I was around you, or even like with a gay man, that happens often, to be truthful. And so when we asked participants their ideas for future research and programming, the most prominent thing was include us. Let us have a seat at the table. And so it is so exciting to hear the talks earlier today about inclusion, belongingness, and having a seat at the table. But the most important thing that came out of it was also include SOGI measures in your studies. That is really important to have an understanding of what firearm violence looks like for LGBTQ people. People wanted accurate reporting of gun homicides, in particular around the experiences of for trans women of color. We see this in the news often, but we don't have accurate reporting for a lot of reasons. In Michigan, we just had a law passed around safety. So just to note that these interviews were conducted prior to that, but our participants did speak about the desire for accessible firearm safety programs and how they were often not included, or that transportation in Detroit is not one that's easy. So bringing those safety programs to the community spaces that they're attending, but also the fundamental issues we're thinking about investing in structural determinants and the structural vulnerabilities, and ensuring that we were investing in jobs and community centers and safe and affordable housing. And while tax credits and tax breaks might be very useful for some members of the community, at the same time, those aren't going to help folks that don't have viable employment options. And then finally, using trauma-informed affirming strategies in our programs. Our participants, and I will say us as a research team, experienced a lot of trauma doing this work and sharing these stories. Our colleague, Jay Stevenson, who came on, actually created this incredible toolkit for us, even just how we went about checking and verifying our transcripts and how to take care of ourselves while we were doing this work. And so our next step is a community report back. I should mention that we also have stakeholder interviews, and we did a neighborhood assessment as well, an activity space assessment that Dr. Avery Everhart is leading. And we'll be sharing these results with the Williams Institute. And we're really interested in exploring avenues where we can really better understand, using rigorous measurement, the prevalence of gun violence among this community, as well as the structural determinants of gun violence. And of course, I want to acknowledge all of the participants for their time and energy. And we were so fortunate to have the University of Michigan, through 3 different sources, support our work. And so I can't thank them enough. And the Ruth Ellis Center, who generously allowed us to do this work in a really safe and affirming space for our participants. And thank you.
My question, on one of the earlier slides, you showed that there was low suicidal ideation and attempt among that group. And as you look at kind of the intersecting factors, I think that's really powerful to see. Were there any conversations and discussions to kind of identify what were some of those protective factors that kept those numbers so low? And what are, any lessons learned on, what protected against having those numbers be higher when you're looking at poverty, being Black, and LGBTQIA+.
Yeah, I think that's a really good point. I think, that the suicide ideation and the high suicide literature among LGBTQ communities is predominantly white samples. And so that's when we start to see really high prevalence of suicide ideation. Now, I don't want to say this was really focused in on gun violence. So that is not to say that the participants that we spoke with did not have suicide ideation, nor had they not experienced suicide attempts. It was just not with firearms. So I do want to make that point. I think that one of the things that came up more that became the focus of this was more the interpersonal and community violence, as opposed to suicide in particular, if that helps answer your question.
Just quick follow-up off of Dr. Underwood's questions. Do you have a sense of gun ownership among this group? Like, was there low access, which could lead to lower rates?
No, they all had access to guns. And I will say that they were, not everybody had access to guns. Some of our participants we spoke to were scared of guns and did not, but they also felt that it was important for the LGBT community, in particular Black LGBTQ people, to carry guns for protection. That was the whole reason for it. But that, people did talk about having guns for safety, to protect themselves. And one thing that I think we need to think about too are people are not necessarily going out and buying guns. They're getting them from friends. There's a lot of different ways that community are getting guns and protecting themselves in communities.
All right. Thank you so much, Dr. Gamal. That was a really informative and rich presentation. So, and a wonderful collaboration between the Institute of Firearm Injury Prevention, the School of Public Health, and the Injury Prevention Center. So, thank you so much. Our next speaker is Dr. Kip Bonnard, who's an associate professor in the Department of Epidemiology and Biostatistics at Michigan State University and a member of the University of Michigan Injury Prevention Center. His presentation is titled Examining Links Between State Opioid Limitation Laws and Suicide Outcomes in the United States.
Thanks to all of you for being here. It's a pleasure to be here, be with all of you. So I am going to talk about our project examining links between state opioid limitation laws and suicide outcomes in the U.S. First, I wanted to give a thank you and a shout out to the collaborators on this, especially Matt Myers, who's a graduate student working on this. He's done a lot of great modeling work on this project and helping us think through some of the important issues with the data. So I think all of us know that suicide is a salient public health concern, especially in terms of increasing rates of suicide in the last 20 years. And it's around the 10th, 11th, 12th leading cause of death in the US in the last few years or so. So we also know that there are links between opioid use and opioid use disorder and suicide, and they're associated with increased risks of suicide. Some of the work that I've done, as well as other colleagues have done, have shown that opioid use disorders linked with suicide, as well as there's a dose-response relationship between dose prescribed and risk of suicide. So given this backdrop, there's been some opioid limitation laws that are intended to limit the amounts of opioids medical professionals can prescribe to individuals. And there is state variation in these policies. There are dosage limits, as well as duration limits. And the previous research in this area has kind of linked these state opioid laws with reductions in actual opioid prescriptions, but they've also linked them with reductions in unintentional overdose, rather. So given these links, we kind of wanted to kind of expand upon this and think about, is there a link between these prescription limitation laws and fatal suicide outcomes? So for this specific aim of this project that I'm going to talk about today, we wanted to estimate state-level associations between these opioid limitation laws and suicide mortality. And for this, we hypothesized that opioid prescription limitation laws would be associated with a decreased rate of suicide death. But that's not to. I also want to kind of also give shout out to a competing hypothesis that potentially it could actually increase these sorts of laws could actually increase suicide mortality if individuals who had pain, for example, weren't given access to their opioids. So there is that competing hypothesis kind of out there. So for this project, we used a couple different data sources and merged them together. For the state policy data, this was derived by Corey Davis. He did a legal analysis. He's a policy expert with this, and he panel coded data for quarter yearly to look at these state limitation laws. And for this specific project, we're looking at non-restrictive policies, so they must cover all individuals. It can't cover just certain prescriptions or certain age groups. And that there's also a duration limit that was less than 30 days for this specific opioid limitation policy. And then our outcome, we used the same quarter-year rate of all-cause suicide per 100,000 in the population, and this was CDC Wonder data. So for analysis, we used a staggered diff and diff approach. Originally, we had used an interrupted time series approach, but because we weren't able to, with that approach, you're not able to look at, have a control group. You're just looking at pre-post. This is kind of an advantage over that. And shout out to Matt for getting this done in time so that we could present it here. And I will say, if anyone wants to talk about some of those, the ITS approach, we can talk about it afterwards because they are similar to this staggered diff and diff approach in terms of our findings. So in this, we use the control groups are states that never implemented a law, as well as the pre-implementation period of laws of states that did then implement. There's a couple of assumptions that there's no treatment anticipation. So that is like a state doesn't anticipate that a opioid limitation law is going to come on the books. And there's also we have the assumption of parallel trends similar to other different approaches. We did also exclude states with a non-robust opioid policy, so to have that's different than the ITS approach that we used. So let's see what we found. So we did find that overall, in aggregate, that a robust opioid limitation law was associated with a reduction of 0.24 suicide deaths per 100,000 population. Now, that might not seem like a lot, but actually, for something that's a relatively rare outcome, that's definitely appreciable. And in terms of thinking about had states that didn't have these policies enact them, we could have saved on a scale of hundreds of lives potentially, if causal. So I think that's important to consider and think about. And then I also wanted to present a little bit of the different kind of grouping results. So these are grouped by when states enacted these laws. And you can see that there were three groups where there was significant reductions in suicide death, but none of the groups showed an increase in suicide death rates pre-post implementation. So that was an interesting finding as well, I think. And then these are just some kind of just checks on our approach, and you can see that in the post-implementation estimates indicate a reduction, and there's a clear reduction kind of over time. There's no like increasing or decreasing trends in that blue. You see, it's kind of just reduced after that period of time. So that's also important to note that they're not increasing or decreasing, I guess. All right. Just to summarize, so again, we found a reduction in the all-cause suicide mortality following the implementation of these opioid limitation laws. These are, again, the robust opioid limitation laws. And then 3 out of the 12 groups showed statistically significant decreasing effects, although no groups showed significant increases, which is important to note. The point estimate, there was only one group that had a point estimate that was even increasing. Again, the effect doesn't appear to be getting stronger or weaker over time, and it appears that the basic model assumptions were upheld in our checks. So again, this is one of the first studies to really look at whether or not these types of laws have an impact on things other than opioid overdose, specifically looking at suicide. And these results do support that association between opioid policies and other relevant health outcomes, and we might be able to think about other ones in the future. And they may help inform prescription opioid policy as well as legislation. So that's, I think, important. Some of the future things that we're thinking about is potentially including more states by extending the analysis period. Also, looking at overdose-specific suicide mortality. So we would try to do that in the ITS models that we were doing. It got a little bit tricky because of small cell sizes. So that was difficult. But I think it's important to consider in the future. And then I think the other thing to think about is really thinking about specific population strata or subgroups who may be more or less affected by some of these policies. So are individuals with chronic pain, for example, actually not doing as well with these policies? I mean, this kind of is on aggregate. So to take those strata would be, I think, important to think about. And then further, we're investigating some of these associations with other non-fatal suicide outcomes. Matt has a paper or had a poster today on this, so you can talk to him a little bit more about it. And we can also, discuss that as well. So I think that is all that I have. I want to say thanks again to the Injury Prevention Center and thanks to the CDC for the support for this. It's been a very, very interesting and great project to work on. So thanks a lot.
I'm just wondering how you account for overdose deaths that may or may not be due to suicide. There are, I think it was over 100,000 overdose deaths last year, and about 50,000 suicides. But of those overdose deaths, it's often very difficult to determine whether it was intentional or not. So I'm just wondering whether that could introduce a bias into the results.
Yeah, so I mean, it is true that these are all based on CDC Wonder data, so it's based on death records from state coded death records. So that is true, and a potential kind of limitation of the study for sure. You could, as one could conceivably, put the overdose as intentional, unintentional together, stratify them, look at that separately as well, which we do here. But yeah, that certainly is based on death records, and that's a limitation of the data.
All right.
Sorry. This is maybe a little bit outside of the scope of what you did, but I'm wondering if you can reflect on what role, if any, you think medical and or recreational cannabis might play in opioid restriction laws and suicide mortality?
Yeah, we had that in here for in terms of like having that as another variable when those policies came into being. Obviously, it's within the state, so it's kind of controlled for with this. But yeah, I think that's an important thing to think about in next steps, and something that we're thinking about and kind of finalizing the results with this. But yeah, I agree. Thanks.
Thank you so much, Dr. Bonnert, for that amazing presentation. It was nice to switch gears and think a little bit about policy. Our next presenter is Dr. Mark Ilgen. He's a clinical psychologist and research career scientist at the VA in Ann Arbor at the Clinical Management and Research Center. He's also a professor in the Department of Psychiatry at the University of Michigan, and his presentation is titled Encouraging the Use of Crisis Lines as a Suicide Prevention Resource.
Wonderful. Thank you, Maureen, for the introduction and for the opportunity to talk with you today. I will be discussing our a brief intervention that we developed that we call crisis line facilitation, and the application of that intervention to two different at-risk populations. And before I get into the talk, I just want to start with disclosures. I, over the past few years, have worked with a couple private companies, including a company that's called B Therapeutic, that's developing a cognitive behavioral intervention that's delivered via an app. And I don't believe that has much to do with what I'm going to be discussing, but it is still focused on suicide prevention, and I want you to be aware of that as a potential COI. In terms of the specific focus of the talk, I'm going to be discussing two different studies that we've conducted. One of them was funded by the VA, and this is a complete study of crisis line facilitation in psychiatric inpatients. And then the second is funded by the CDC through the Injury Prevention Center. That's an ongoing study where we have preliminary outcomes in Michigan National Guard soldiers. And I guess I should note that the views here are my own and not reflecting those of the funder. So both of these presentations are focusing on military personnel or veterans. The reason for that is we've known, based on about 2 decades of research, that military veterans are significantly increased in terms of their risk for suicide relative to their peers. The risks vary, but depending on the age and gender group, they're about 1.5 to 2.5 times more likely to die by suicide than other members of the population. And so they're a group that's appropriate for and could benefit from specific suicide prevention intervention. And one of those interventions that began in the early 2000s is something called the Veterans Crisis Line. This is also called VCL. The VA likes acronyms. And even though it has the word veteran in the name, it applies to any military personnel member, any veterans or their families, and they can call and get help in if they believe that someone is approaching a suicidal crisis. And the US rolled out 988 as a national resource for suicide prevention. And that was based on a lot of the lessons learned from the Veterans Crisis Line, as well as private suicide prevention initiatives. And with 988 as a national resource, you can now access crisis prevention services at any time via phone, text, or chat. And within that, you can press 1 and have access to veteran or military specific resources. So with the use of crisis lines, people often wonder, are these being used? We've done a lot to roll them out. Is the population using crisis lines? I think the answer to that is a resounding yes. These are data from the start of this year, the month of January. And what you'll see is that 988 and its affiliated centers received over 500,000 contacts within that 1 month alone. And about 60,000 of those were directed to the Veterans Crisis Line. I still, some ways out of habit, refer to these contacts as calls, but it's worth noting that they involve both phone, text, and chat contacts, although the vast majority of contacts still involve the telephone. So that's a very positive way of viewing utilization of crisis lines. But what about upstream? Not just those who contacted the line, but those who could benefit are people who could benefit from crisis lines actually reaching out. And there, it's a little harder in terms of methodology to study this, and the answer is probably less encouraging. This is a survey from 2023 where they identified a high-risk group of individuals and asked them if they've ever used a crisis line. And you see that only about 5% of those with serious distress said they'd used a crisis line before. And when asked whether they'd consider using one in the future, less than a quarter said they would consider that. So with that and similar findings in mind, we developed a intervention that we call crisis line facilitation. This is a single session intervention that uses principles of motivational interviewing and general discussions of how people cope with a suicidal crisis to help them reconsider how they could reach out for help during a period of crisis in the future. One key component of this intervention is that we involve a practice call to the crisis line. And for this, the therapist and the patient talk about what it might be like to call a crisis line, and then they actually pick up the phone and dial the crisis line together and discuss it afterwards. And we've found this to be a really powerful way of shaping their perception of and hopefully potential to use that resource in the future. Sometimes we talk about this, people say, well, why are you practicing something as simple as calling on the phone? Probably everyone knows how to do that. And the reason is we know that behavioral rehearsal is a powerful tool to help people overcome barriers to reaching out for help in times of need. And we know this from a lot of different contexts. It's true whether you're talking about complicated behaviors you're practicing, like pilots in a simulator, or something simple like a fire drill, or in this case, a tornado drill, where kids are going in the hall and putting their head in their hands. And the idea is that if you do this enough times before someone's in a high-risk situation, they're going to be more likely to do it and execute that when the crisis comes up in the future. So in terms of the two studies, this is the VA study, which we call the link-up study. It recruited psychiatric inpatients who were hospitalized for a suicidal crisis. Our N was a little over 300, and they were randomized to either receive the crisis line facilitation or control condition while in the inpatient unit, and we followed them for up to a year. In terms of subjective indicators of how people responded to the intervention, these are ratings of confidence in and comfort with using a crisis line, and you see that those go up from baseline to after the session, and those increases are much greater in the individuals who receive the intervention relative to the control condition. In terms of the primary outcomes, we looked at both calls to the crisis line and suicide attempts. This is the calls outcome slide, and you see there's a lot of overlap. We did not see any impact of the intervention on a greater likelihood to call the crisis line in those who got the intervention relative to those who did not. But when you look at suicide attempts, you see fairly nice separation here, where those who received the crisis line facilitation intervention were less likely to make a subsequent suicide attempt over the follow-up period relative to the control condition. So in terms of takeaways from this study, we found that it was feasible to deliver a single session intervention during an inpatient stay, that patients and the clinics found the intervention to be valuable. And we see an early signal of the effect of this intervention on the outcome we care most about, and that's suicide attempts. There have only been a handful of studies that have shown benefits of an intervention on future suicidal behaviors. And most of those studies involve much more intensive interventions. So we were encouraged by these results and motivated to think about other populations that could benefit. So that brings us to the CDC-funded study. This is what we call Project Connect. And for this study, we have modified the crisis line facilitation approach to be delivered in Michigan National Guard soldiers who are in for their monthly trainings at a National Guard armory or facility. And they participate in this crisis line facilitation intervention or not. For this study, we randomize at the unit level, and we modify the intervention so it could be delivered in group format. Our idea was that it's pretty labor intensive to go one-on-one with someone to talk through what this process would be like. And so we wanted to have something that was would fit more easily in the types of training that National Guard do. So we have this as a group-based intervention. It was modified further to make it more relevant beyond just someone's individual suicidal crisis, so that they might be more willing to reach out to support a friend or relative if they were feeling suicidal. And we did that for two reasons. One, because it might be helpful to the population to have to help shape that perception of addressing risk. And also from a feasibility perspective, it's hard in a group full of National Guard soldiers to ask people directly, well, how about the last time you were feeling suicidal? And, in-depth questions about their emotions. And instead, we engaged them in discussions what they would do about someone else who might be struggling. And they were very eager to have that conversation because they think often about how to support their fellow soldiers. So again, this is an ongoing study, so we don't have the final outcomes, but in terms of the relevance of the intervention to this population, many of the National Guard soldiers reported personal experience and exposure to suicidal events, either non-fatal attempts or losing someone they know and care about due to suicide. And the actual utilization of the crisis line was pretty low in this population, is less than 10%. We were a little worried going into this intervention that the population would already be saturated with exposure to information about the availability of crisis lines, but and people would kind of feel like they were already aware of the content. But less than half of participants at baseline reported they felt like they knew what to expect when calling the crisis line, which opens the door to having a group of individuals who would benefit. And most of the participants said that there was at least some of the content in the intervention that was helpful to them, relevant, and could be useful to them in the future. The bottom part of the slide just looks at, again, these changes in self-efficacy. And what you see, in this case, it's only in those people who receive the intervention. What you see is that confidence and comfort with calling the crisis line went up from before to after receiving this intervention. So just to summarize, I believe, and I think many people do because of the significant investment that our country made in 988, that crisis lines play a crucial role in suicide prevention in this country, but we're often missing people who could benefit most from these interventions. So it's important to think creatively about how to reach people who could benefit, to have a different dialogue with them about their perceptions of reaching out for help, and to come up with ways to help support them reaching out in times of need. And the preliminary results show some benefit of this crisis line approach, and we're eager to think through what are other ways and other behaviors that people could consider and utilize in times of crisis, and how could we support them. This is a intensive and labor intensive and emotionally intensive type of work to do. And I'm lucky to be a part of a large team, many of whom are here, who do this work and work with these at-risk individuals every day. And I'm very grateful for the work that they do. Thank you. Yeah, sir.
Thanks for this great talk. I was curious about the survival curves you showed. Did you do any qualitative work to understand, like, people aren't actually calling the crisis line, but they're still committing, fewer attempts? Is it because there's just some benefit of knowing that they have this option available to them, or what do you think is going on there?
It's an excellent question. We have speculated, but we don't really know. We did not have qualitative data in the VA study, so we don't really have a way to dig deeper into that. My hunch is that in the VA, there are, especially over the past 5 to 7 years, there's been a huge emphasis on suicide prevention, and that I didn't show it, but somewhere north of 80% of people were using mental health services after leaving the inpatient unit during that time period. So I think that they were already pretty hooked in to different suicide prevention services. But we hope that this idea that they can stop and think about what they can do and take action that's different than following through on an attempt may have been beneficial and could have been what paid off in terms of what we saw with the suicide attempt.
Thanks for an interesting talk. In the first study, as I recall, you had 300 inpatients at the VA.
Yep.
And half were intervention and half were controls. So I think you said the primary outcome was self-reported suicide attempts.
Correct.
So I'm wondering, among those 300 in that following year, did the intervention group show fewer actual suicides? Because obviously you weren't going to be able to contact people who ended up completing suicide. And I'm just wondering what the result was on that.
Yeah, so we did have a handful of suicides. I'm going to forget the exact number, but I want to say around 4 or so that occurred in the during the follow-up interval in our 300 veterans. We did not see any statistically significant impact there, nor when we eyeballed the results did they look different between groups. And so, the challenge with this type of work is you're really underpowered to look in depth at the outcomes you care most about. And in this case, we didn't have power to look at suicide death closely. We did do some sensitivity analyses. I don't think I shared the follow-up rates. We had pretty high follow-up rates, which often happens in the VA where you can use the electronic medical record to track people. They were over, I think, 83 or 84% out to a year. But we did some sensitivity analyses where we assumed that all non-followed individuals had deceased by suicide and encountered them in that way or not. And those did not fundamentally change the results of the study.
Thank you so much, Dr. Ilgen. That was also a very interesting presentation. Our last presentation before lunch is I'm excited to say that we have Dr. Jeff Hoffman here. He's an associate professor at the School of Nursing, Department of Systems, Populations, and Leadership. He'll be speaking on the effects of Medicare's Hospital Readmission Reduction Program, HRRP, on fall-related injuries among older adults.
Hello. It's a pleasure to be here. Thank you to the IPC for this wonderful set of presentations, and thank you all for sticking through with the last talk here. So I'm going to talk today about this program called the HRP and falls among older adults. So it'll probably come as no surprise to folks here that falls are a pretty big problem for the older adult population. About 10 to 15 million older adults in the US, that's adults 65 and older, fall each year. And a lot of those entail injuries that require medical attention. And so the statistics are fairly staggering in terms of how big of an impact falls can have on morbidity and mortality. They're the leading cause of acute care utilization for older adults caused by injuries, so much more than car injuries, other sorts of sports-related athletic accidents. And we know a fair amount about where falls happen. And so most falls happen in the home, although there are some that happen in the built environment within communities. But there hasn't been much work done about where in space and time. So we know in space where they happen, but in terms of where in time they happen, a little less has been known. So we've done some prior work that shows that high frequency periods for falls really happen around a hospitalization. And a sort of interesting finding, we had long known that falls happen after a hospitalization. But it turns out that in the run up to a hospitalization, for hospitalizations that don't actually include falls themselves, there are a lot of falls. You can see the steep increase in falls. It's about 30% week over week increase in the risk of a fall. And so this constitutes in the month prior to a fall, a pretty dramatic 300% plus increase in the risk of a fall for an older Medicare beneficiary. And so falls really function as sort of an iceberg phenomenon where you don't really know what's going on under the surface, but this is how we've interpreted it in a way that a fall is an indicator, sort of a signal of some sort of acute decompensation or something going on that might lead to poor mobility or other issues resulting in a fall, resulting in a hospitalization. At the same time, we also know, you can see on the right side of the figure, that falls cause a lot of readmissions. People come back to the hospital for a fall. And so some other work we've done has shown that when you examine the leading diagnoses for readmission, falls are the third leading one. And in fact, for some higher risk populations, those with cognitive impairments, the second leading diagnosis. And for those who started up in the hospital because of a fall-related injury, it's the leading readmission diagnosis. So in space and time, we're learning a little more about where falls happen and what causes them. At the same time, despite increasing knowledge about these things and widespread efforts at prevention, amelioration of fall risk, fall injury rates continue to increase. We have lots of geographic variation in them. So we know that every year fall prevalence increases by about 2%. That's about 1 million extra falls annually. And substantial geographic or twofold variation in fall risk across the country. So all of this from a health services researcher perspective is a great place to think about implementing some sort of intervention or thinking about something's not going right with the quality of the approach that we're using at present. So some good news, despite that somewhat ominous background, is that falls are, in the words of Neil Alexander, who works for the IPC, relatively preventable. That doesn't mean it's a slam dunk, but there are things that we can do. And from what I've shown here, we thought that there might be critical junctures where you might really have some impact, and that is around the hospitalization. And so the reasons in particular around the hospitalization is that this is a critical juncture where you can also have interventions from all sorts of clinical experts, occupational therapists, people who identify you as at risk for a fall, pharmacists, interdisciplinary team members. Everyone is sort of there who can be part of the village that helps provide quality of care, to maintain your mobility, to identify risks, to get you to the right places once you leave the hospital. At the same time, we know that critical junctures like these at the hospitalization have been targeted by a lot of policies in the Medicare program. So one in particular that I'm going to focus on today and tell you a little bit about is the Hospital Readmissions Reduction Program. Now, what's most interesting is that most of these quality programs in Medicare, including the HRP, do not at all focus on things like falls, despite their importance and despite the nature of their high frequency periods around these areas that are policy relevant, like hospitalizations. We typically measure things like all-cause readmissions, mortality, all sorts of other things that are available in claims data, but not fall-related injuries. So we decided, because we think that falls could and should be a policy-relevant outcome, what if we looked at the hospital readmissions reduction program in the context of potential spillover benefits on fall injuries? So HRP, for those who are unfamiliar, I know speaking about falls after some of the earlier topics is a little bit off to the side. And so brief background, it's a mandatory policy introduced under the Affordable Care Act. That means it affected about 3,500 American short-term acute hospitals in the US. They started off with a set of 3 particular diagnoses. They were interested in identifying quality around those sorts of conditions. The program was announced with the signing of the ACA in March 2010. It was actually implemented in October 2012, 2.5 years later. And we know that it was associated with modest early reductions in readmissions after the announcement period. We also know that interventions that could potentially benefit readmission prevention are likely to spill over into fall prevention. So these can include things like transitional care, nursing-led education, teach back, red flag signs about things that could send you back to the hospital, medication management, a visit to the home or a telephone call, making sure that you contact a primary care physician after discharge, all sorts of care coordination and management that's sort of re-engineered and improved that was supposed to occur, and in many cases is believed to have occurred after the introduction of the HRP. So these are reasons why we might expect some spillover effects onto fall injuries. So our objective was to look at the HRP and see whether an outcome that was not explicitly targeted in the program, which are fall injuries, were actually affected, and if so, how, what potential mechanisms. So we looked at changes in fall-related outcomes and a number of hospital-specific organizational and behavioral responses that might have led to any observed change in fall injury. So we used a bunch of Medicare national data from before and after the program's announcement and implementation. We looked at older adults, and we had a control group, which I can talk about later if anyone's interested, and looked at a host of outcomes. So the key ones were 30 and 90-day fall injury rates, that is 30 and 90-day windows following the date of the admission to the hospital. We also looked at the primary outcome for the program, all-cause readmissions, to see if we have alignment between any decreases in all-cause readmissions and fall readmissions. And then for mechanisms, we looked at a whole host of things. Did the hospital length of stay change? Were you discharged to a different place, home health, with a home health referral, a skilled nursing facility referral or not? Did you get a PCP visit after the discharge? Were you seeing changes in the destinations of where FRIs were treated? Maybe rather than in the hospital, hospitals said, let's keep patients seen in the ED from being admitted to the hospital so we can avoid penalties. So we looked for those sorts of things. And then we also looked at whether the types of patients treated by hospitals changed after the introduction of the policy. In other words, if they were trying to game the policy. So we did an event study analysis looking at before and after, as I said. And so I'll just get quickly to the results here. So what we found was that the announcement back in March 2010 of the HRP, and again, the announcement is critical because at this point in time, administrators of hospitals knew the details of the policy, how the penalties would be calculated. And they also knew that at implementation 2 years later, the performance data used to create the penalties would start back in 2008. So they knew they had to get going in 2010 at the announcement. So in fact, we saw decreases instantaneously after the announcement of the policy for 2 of the 3 of the starter set of conditions for heart failure and pneumonia. And the decreases in fall related outcomes were fairly substantial in size. So for 30-day fall-related injuries, we saw 14%, 11% decreases in 30-day readmissions for fall-related injury for those 2 conditions. And for 90-day fall-related injury, we saw concomitant changes. And we looked at 90-day just to see if hospitals might say, let's just readmit at the 31st day so we avoid a penalty. So we're kind of trying to tease out any real changes from sort of gaming-related changes. At the same time, much like with the key targeted outcome for the program, all-cause readmissions, which hasn't seen reductions in all-cause readmissions from HRP after implementation. They were only seen after announcement. We saw the same thing with fall-related injuries. So after implementation, we didn't see any reductions in FRA changes. That said, the initial reductions after the announcement were sustained out to 2 years. So there were lasting changes. They dropped and then stayed down. You can sort of see up here, for those who prefer things numerically, but here visually, you can see some of the changes. So these were the, I'm saying instantaneous, but sort of more immediate changes that we saw after the announcement of the program in March 2010. But you can see that going out to the right side, that these changes were mostly sustained toward the end of the program. So then, as I said, the second objective was to look at potential mechanisms to see were these true changes, what might they be due to? And we didn't see a whole lot of evidence in terms of hospitals gaming the system. We didn't see changes in the types of patients seen. Hospitals saying like, okay, fine, we'll avoid penalties by just admitting healthier patients or younger patients. We also didn't see evidence that they were gaming by not admitting patients with a fall injury who went to the ED or to an outpatient setting. That wasn't happening, so that's good news. At the same time, we also didn't see evidence of better outpatient care, if you will, of patients who had a fall injury being seen a primary care physician after the hospital discharge. What we mostly saw in terms of mechanisms was reductions in hospital length of stay and fewer referrals to skilled nursing facilities. And the second of those we thought was particularly of importance, given that skilled nursing facilities are associated with a lot of preventable adverse events. And so this change, dramatic change in the discharge disposition, might be sort of related to some causal mechanism that helps explain some of the results that I've shown. So in conclusion, so discussing the results, HRP is this big mandatory program. It doles out pretty massive penalties that hospitals and many policy advocates more or less deplore. They think it's a poor quality measure and really should be sunk, the whole program. But we found it pretty interesting that there may be an unexpected benefit for an outcome that I think is of real importance to independence and well-being for older adults and their family members. We saw substantial decreases of more than 10% of shorter and longer term FRIs. We saw that they were sustained 2 years after the implementation. We didn't really identify a mechanism, but we did rule out sort of administrative gaming or ways to sort of cheat the system, if you will, to the extent we could address those things. Our best guess is that some of these crossover benefits of intervention strategies to reduce readmissions, which are improved transitional care, re-engineered discharge programs, following the patients by interdisciplinary teams. These are the exact sorts of things that could help both readmissions and fall injuries, particularly given that fall injuries are a leading cause for readmissions. So you're a heart failure patient, you have someone help monitor you, give you virtual feedback over time. That's going to benefit both all-cause and fall-related readmissions. We saw smaller effects for heart attacks than heart failure, but that was also because we started with a smaller baseline fall injury rate for heart attack patients. Other potential mechanisms of were there inpatient within the hospital changes in quality, it's just hard to know from the claims data, but there are a host of things that could happen in the hospital. We know interventions have been targeted to be delivered directly in that setting, but those are unavailable for us within the claims data, particularly in the period we studied. As I said, SNF referrals were down fairly dramatically, both after the announcement and implementation. So that is another strong hypothesis for driving our results, which is avoiding some of the preventable adverse outcomes, sending people home as necessary, keeping people out of the hospital, getting people out of the hospital more quickly, where they can be sort of decompensate even more. The longer we're in the hospital, you get post-hospital syndrome, poor nutrition, poor hydration, not enough sleep, not enough moving around. These are all things that might, in some cases, be beneficial for the clinical course of care, but in terms of function, regaining function after and avoiding falls after you get out of the hospital, they're pretty not great. So optimistic take on this is that falls continue to be a huge worry. Their prevalence is growing somewhat unabated despite national prevention efforts, CDC educational campaigns, a huge multi-center STRIDE trial that was supposed to sort of be the holy grail, and that didn't really work out. That said, there are national programs where people haven't really been exploring these sorts of outcomes, but they may be, to the extent at the margins, making some improvements around fall injuries. So that's my optimistic take. Again, I'd like to thank the Injury Prevention Center for their gracious funding of this project and my co-authors on the project. Thank you.
Thank you so much for all of our presenters. We'd like to thank all of our attendees for coming today, for the collaboration and the opportunity to connect. And hopefully you were able to do that today, and you'll continue to be able to do it during our lunch, which we'll be having next. Please stay connected with us to stay up to date on Injury Prevention Center events and happenings. Please become a member. You can scan the QR code. There it is to get more information. In addition, please view our online program for more information on our keynote, flash science, and poster presenters today. We invite you to, of course, stay and network and enjoy lunch. And lastly, in the next week or so, you'll receive an evaluation. Please fill it out. Provide us feedback. We're happy to always improve these events in the future. Please note the evaluation is required to request CHESS credits or a certificate for attendance. And you can find information on how to obtain a CME at registration or in the email. So thanks again for coming. And someone wanted me to announce something about a picture, but I couldn't hear. Take a picture of attendees out front.
It's everyone, the whole world.
Yeah,
I'm doing it right out here.
Wow, that's cool. Okay. So thank you everyone for coming, and please enjoy lunch.